in. Next week is our exam, right? So we want to ask as many questions, clear up any muddy areas. I'm hoping that you listened to the videos from, what's it, Sarah Register or whatever it is that I posted. There's 2 of them. I hope you found them beneficial. I would be basically saying the same thing, so don't feel the need to do the lecture per se. There's a PowerPoint, you can take notes or read most of the PowerPoint. There's a lot of writing, you know that's not my style, right? Usually I leave a lot of things blank. So we're taking a little spin today and switching things up, and we're gonna bring class to clinical to class. So we have a case. It's an NGN style case. It was just posted this morning because I had no internet. Makes life really fun when you're trying to do stuff. You really find out how dependent on technology you are. So we'll go, our class is really going to be going through this case and kind of pulling it apart and asking questions related to this as we go. So to get our heads back into AKI, acute kidney injury, we're going to do a quick little summary, right? So I don't know when you watched this video, maybe it was last week. So I want us to all be on that same page. I didn't bring the blank one down. On the course, they have those concept map templates. That's basically what I did, was fill one out from your PowerPoint, from your book, whatever resources that you're using, and wrote it right here. So it's a great little overview, one-page paper. If what you're doing works, great, don't change it. If you need some new ideas, this might be one that you find beneficial. So what's AKI? It's a sudden loss of functioning in that kidney, and if it's not treated promptly, it can lead to chronic kidney disease. And we don't want that, right? We don't want any kind of renal insufficiency, any kind of chronic kidney disease. So what's our focus? One, to recognize it, and to do something about it. That's our goal as nurses. What's the patho? Why does it happen? Well, it's related to either the pre, intra, or post. Why it occurs. Who's at risk? Anybody who has pre, intra, or post. Pre. What's pre mean? Before. Do not make it complicated. Use the words to help remember things, right? So pre-renal, it's before the kidney. If I lock the doors, can you come into the classroom? If we can't get the blood to the kidney, can the kidney filter it? No, so it's before the kidney. Something's going on before the kidney. It can be related to decreased cardiac output. Maybe the heart can't pump so well because they have some cardiac issues, whether it's heart failure, or maybe they had an event that just occurred and lied, and now we've got some damage to that heart, and it can't pump effectively. So decreased cardiac output. The kidney needs a good 25% of that blood flow to go right to the kidneys to be filtered to make urine, remove all the waste. Any kind of hypovolemia, low blood volume, whether it's related to a bleed, right? So blood loss, or intake. I simply just don't have enough fluid in the pipes in order to get to the kidneys to be filtered. Burns. We go to burns at the end of the semester, but there's a lot of fluid shifting in burns, and it's not in the intravascular space, it's all in the extravascular. So again, it's not in those pipes, it's not in the vascular system. So whether it's decreased cardiac output, hypovolemia, or simply there's a blockage. Maybe there's some kind of thrombus at that renal artery. The blood flow comes off the aorta, goes to the renal artery, to the kidneys, right? To the glomerulus, gets all filtered. So if there's some kind of blockage, maybe from a thrombus, or if the renal artery is stenosed, I won't open that door too much, we're not going to get enough blood flow in. A lot of patients are pre-renal. Can fix it very easily. How do we fix this? Fluids. You need to get some more fluid in that system. Okay. Intrarenal, within the kidney. There's damage directly to the kidney. It could be from prolonged pre-renal. If you're in this state for long enough, you're going to have some acute tubular necrosis. The tubulars are going to get necrotic. They need that oxygen. They need that blood flow. Maybe there's direct damage to the kidney, an infection within there, glomerulonephritis. Maybe we've administered medications like aminoglycosides. What's that? Your gentamicin, vancomycin. Maybe they're getting chemotherapy that's toxic to the kidneys. NSAIDs over a prolonged period of time changes that structure right within the kidney. What do we do for this category? So adjust or discontinue the medication, depending on what it is. Sometimes we can't discontinue it, but we could adjust the dosage, not we, the provider. Okay, and what else might we need? Fluids. Fluids. That's not a good phone call. Great. Fluids, we want to wash out those kidneys. Okay? Post-renal, there's some kind of an obstruction. The doors are closed, you're in the kidney, you can't get out. Well, how do you get out? You have to relieve the obstruction. Is the obstruction from BPH? Is it from a tumor? Is it from a kidney stone? So how do we treat that? Some kind of stent, maybe surgery, physical removal of some sort. Maybe they need a catheter placed. Okay? Or it could be some kind of neurologic event, right, where they have urinary retention. And we just have this massive distension, and it kind of backs up into the kidneys, causing acute kidney injury. So relieving that obstruction, opening the door, letting the urine come out. We can make urine, but it's not coming out. Okay, so this is why we have this acute kidney injury. It's where it's taking place. So what do we assess? Well, always our vital signs, right? Don't they tell us how hemodynamically stable our patient is? The labs, what are your renal function labs?
GFR, BUN, creatinine.
Your creatinine, your BUN, your creatinine, and GFR. Which one's the best?
GFR.
Your GFR, that's that filtration rate. What's the next best?
Creatinine.
Creatinine. Creatinine's the only place that's excreted from the kidney. If we have a buildup of creatinine in our blood, that's bad. Bad, 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 right? We start having symptoms of uremia, azotemia. What other labs? Your electrolytes.
Potassium.
Our potassium, that's of course always number one. K is king, right? But we're also worried about which other ones?
Sodium.
Our sodium, magnesium, phosphorus, definitely. There's one more. Calcium. Those are our big ones. Potassium, phosphorus, and calcium. We have that with Professor Anderson, and it's good. You're going to get more in depth with that with Professor Kelly with chronic kidney disease. Okay? Urine output. What's oleuria mean?
Low urine output or no?
Low urine output. Do we have a number? Less than 400. Anuria? None. A, right? None. Without. Or polyuria?
Too much.
Way too much, right? So this is hitting on those vocabulary slides. I think it's the first slide in your PowerPoint. So looking at that urine output, the amount, and then what else are we assessing in that urine? Color. How does it look? What's the specific gravity? Is there other stuff in it? Stuff meaning fats, red blood cells, right? Ketones, glucose, proteins, all those things. And our daily weights, right? Isn't weight the best indicator of your fluid balance? So if you're working on a unit that has renal patients and you're not doing a daily weight, that nephrologist is not going to be happy with you. No different than they will not be happy with you on the cardiac unit, right? It's a guarantee you need that daily weight. It's almost like part of their vital signs. They base our treatment and fluid restrictions on urine output weight and these labs. So these are your key assessments. Yes, we're going to be assessing for fluid balance, that excess. What's excess fluid balance?
Too much fluid.
Too much fluid. So how does a patient appear? What are some signs and symptoms? Edema, JPD, crackles, maybe some shortness of breath, bounding pulse, tachycardic. What's their blood pressure?
High.
Elevated. Fluid volume deficit.
Not enough.
Not enough. Dry membranes, skin cover. Low blood pressure. Very different, right? All right, metabolic acidosis. We know the kidneys are responsible for excreting those hydrogen ions. So you have the risk or the potential to have metabolic acidosis. How do you know when somebody has metabolic acidosis? So Kussmaul's breathing, that rapid, deep breathing. Maybe they got some neuro changes, a little confused, fatigue, weak, nauseous. So those were some of our signs and symptoms. We kind of went through them. We didn't focus too much on the electrolytes. But again, I'm most concerned about the potassium. So what would you want to do for someone who's got an elevated potassium? EKG or put them on a cardiac monitor. How do we get rid of that potassium?
Insulin and dextrose.
So we can do the insulin dextrose, shift it back into the cell. We can give K-exolate and that gets rid of it, right? We have bowel movements. Are we okay? Here's your K-exolate. I just moved my bowels. Are we good with that? Do we want to hold it, continue to give it? Continue to give it. That's what we want, right? What are some things that you're looking for on the monitor, on that cardiac monitor?
ST elevation. peak
Not ST elevation. ST elevation shows what?
Heart attack.
Shows MI, shows ischemia.
Why
So we
QRS?
want peaked T waves. Well, we don't want them, but that's what hyperkalemia is. You see some peaked T waves,
QRS.
a wide QRS, or a prolonged PR interval. So if you put your patient on the monitor and we're starting to see some of these changes on their stress, well, we need to do something about that potassium, right? Because now we have the potential to have arrhythmias. You don't want that, right? That can be lethal. So that's why I tend to go with potassium. I know Professor Kelly is going to focus on phosphate and calcium as well. Okay, risk factors, well, certainly anything related to this. Otherwise, diabetics, patients who have hypertension, coronary artery disease, well, diabetes and hypertension, we see all kinds of microvascular and macrovascular changes. So that's going to put them at risk. Coronary artery disease and chronic kidney disease. So you can have chronic kidney disease and then have an episode, an exacerbation, an event on top of that of acute kidney injury, where your lab values all of a sudden now get profoundly worse maybe due to one of these reasons, and if we recognize it and catch it and treat it, then the patient can go back to hopefully their baseline chronic kidney disease. If there's some damage there, maybe it gets a little worse and they go into the next stage of kidney disease.
Their levels already abnormal, so.
Their levels are already
How
normal.
would you know if it was an acute situation?
So how do we know if it's an acute situation? Great question. A change in the baseline. So if my creatinine is normally 1.5, and let's say my BUN is 32, now when the patient comes in, maybe it's routine lab work, or maybe they have some kind of signs and symptoms that they're presenting to the emergency department with, when we do our labs, well, now their creatinine is 2.1, and their BUN is 8. So, again, what do you do? What's one of the things that you do when you first see someone's labs are off, their BUN, creatinine, and GFR? Do they have a previous one? Are we trending in the same way? Is it better? Is it worse? Does that make sense?
It does.
She doesn't like
I
that
was
answer.
like, how do we know the last time they had their labs? And I've seen.
How do we know the last time we had someone's labs?
2 point something, so.
So you're looking in the chart. If a patient has chronic kidney disease, should they be aware? Should they know their number? Yes, they should. Because they should, in their treatment plan, they are very much in tune to eventually I'm headed to renal failure, end stage. And there's these stages, right? And the further I go along that path, I'm going to end up on dialysis someday. So I want to not go there. I need to know how to promote health in myself and prevent that from occurring. One of those things is, what stage of kidney disease am I in? How bad are my numbers? Any kind of infection, we kind of lead back to this, right? Dehydration, our volume, any nephrotoxic meds, post-surgery. You're on a surgical floor, you're looking at the urine output, right? You're looking at the BUN and creatinine, the effects from anesthesia, the hypovolemia, how much blood loss do they have? Kind of comes back to the why over here. Our diagnostic, our labs, whether it's our renal function, our electrolytes, our UA. And our problems really relate to that electrolyte imbalance and our fluid balance. That's the job of the kidneys, right? To maintain fluid balance and to maintain that electrolyte balance. Yes, we have some nutrition, a risk for infection, and some teaching. And our complications are, you can end up with chronic kidney disease if we don't correct it soon enough, and the patient's at risk for infection. Usually their mortality, high mortality, is because they got an infection. So pre-renal can lead to intrarenal, post-renal can lead to intrarenal, and intrarenal over for a long time leads to chronic kidney disease. Patient's sad, bad.
I have a question.
Sure.
For which one of these, external injury, they want to pass them, and it is which?
Direct injury. Direct injury to the kidney results in which type? Intra, because it's within the kidney. Okay. Rhabdomyolysis, intra, because it's within the kidney. That breakdown of skeletal muscle, the myoglobin gets all stuck in the filtration, and the tubules clogs it all up, causes acute tubular necrosis within the kidney. Not enough volume, can't filter, can't even get there. This is within the kidney. The nephron is damaged some way, somehow, from something. And post-renal, it works just fine, but it can't get out. Okay? Good? All right. Are we ready to start our case now? So we've got our head into it. We're still going questions in here. Go ahead.
I was trying to figure it out last night, Google wasn't helping. What is the difference between the azotemia and the
So azotemia is an increased BUN, creatinine, GFR decrease. So you have those abnormal values. It's a buildup of nitrogen waste. And uremia is like the next step higher. Unfortunately, I tend to go like this. I don't mean to, because uremia, I think of uremia as azodemia and azodemia as uremia. But technically, uremia is that next step where now you're feeling fatigued, nauseous, so it's worse. So patients are immunocompromised with acute kidney injury, you're more prone to an infection, obviously not recognized, can lead to sepsis.
Could you say that again, please?
Sure. Let me say it easier. So what's going to kill your patient? Infection. The AKI patient, infection. You have to be very, because they're at risk for infection.
What exactly is making them at risk for infection?
I don't know that answer. I just know that that's their high mortality. It's a complication that they have. It's a buildup of all those wastes. Maybe because of the way that they feel. I couldn't tell you the pathway on that. If someone wants to look it up, please do. But it's not like your white count is low or anything like that. But you are immunocompromised in the sense that your body is weakened and more prone to infection. All right, I'll hit the lights.
Usually caused by dialysis catheter insertion.
Dialysis catheter insertion.
It says risk for infection as a result of volume overload, dialysis catheter insertion, and secondary manipulation, inflammation of the kidney leading to organ crosstalk and impaired host immunity.
I don't like that. That's all better. Okay, so this is the case that was posted, and I'm sorry I didn't post it earlier. Again, I had challenges with internet. My hotspot decided to give up. Okay, so let's focus on this, because I do want to be able to give you guys a break between when I'm done and Professor Kelly comes in. All right, so the clinical case, I'm going to have you read through this first page. Actually, the first 2 pages. First 2 pages. And yes, we do have a select all that apply for our question number 1. But you might want to look through these first 2 pages and highlight, circle, anything abnormal, concerning, something that you would want to potentially follow up on or be mindful of. So I'm going to skip right through it. I'm going to come to here. I'm going to give you a couple of minutes to do that. It's in the course right where the PowerPoint is. Yeah, we didn't even get there yet, but we're going there. You should be reading page 1 and 2, highlighting anything that's concerning to you. I just want you to get to know the case, because all of these questions are related to that case. Page 1 and 2. So let me back it up. Thank you for clarifying. So right here. So here's your case. A little report, the past medical history, what the patient has ordered for meds, and then this is your assessment. I'm gonna make it smaller so it fits. These 2 pages. So the rest of our questions as we move forward are going to keep relating back to these 2 pages. So basically, you're scanning the chart, right? So let's look at this. When you scan the chart, again, I'm not sure how you do it, but when you first hear report, what are some things in this first paragraph that might be concerning? Now, I don't know anything ahead yet, I'm hearing this for the first time. What would you highlight in this first paragraph?
That's concerning to me. How do I know that that's not or anything?
Well, it's something abnormal. I don't know yet. Like, these are things of, I got an 84-year-old, okay, they're an older patient that I'm gonna be caring for, maybe a safety risk. I don't know how old they are, right? That's what I think when I look at age. Pneumonia, okay, so something respiratory. Oh, acute kidney injury, okay, so we're talking kidneys, fluid balance. We're talking electrolyte imbalance. I need to go look at some labs. These are the thoughts that kind of come into my head when I'm thinking like a nurse, right? These are thoughts that should start to be coming into your head as you're starting to read patients' charts. Yes, are you starting to see that, feel that now, instead of just randomly writing things down? Take your time and think about what it is that you're reading and what it means to you and how you're gonna assess your patient and treat your patient, develop that plan of care. So he's on oxygen. I mean, I don't know what his past medical history is yet, but most people normally don't wear oxygen. So I know I gotta do some kind of respiratory assessment now, but he's there for pneumonia anyway. Getting med treatments for shortness of breath. Oh, why is he short of breath? Okay, well maybe it's the pneumonia. He needs someone to walk beside him because he's got an unsteady gait. All right, so he's fall risk, hope he's close to death. Poor PO intake. Little urine output. Oh, skin's dry and flaky. Okay, get out the lotion. And fluidlessness or extraction, right? Then open a wound, great. He's 84, probably immunocompromised just by his age alone. And 1 liter of fluid was given. Okay. Now, is this all pertinent? I don't know yet, but these are things that make me think of something else. Is there anything else here? What's that?
I put males, I was thinking, maybe prostate obstruction.
Okay, 84-year-old male. Okay, I would buy that. Past medical history, hypertension. Who doesn't have hypertension? Okay. Diabetes. Hyperlipidemia, anxiety, and COPD. Oh, COPD, wonder if he wears oxygen at home. Oh, no wonder why he might have pneumonia, that's a pretty high risk. So those are some thoughts that I have from that. Hypertension, acute kidney injury could be a risk from that. How bad is this? Certainly has poor PO intake. I wonder who he lives with. Is he safe at home? I don't know. How bad is his gait? Maybe he can't go back there. These are all things that I'm thinking. Solumetrol. What do you think when you see solumetrol?
Immunosuppressant.
Immunosuppressant, longer term. So the patient might have some inflammatory process occurring. I don't jump right to inflammation.
You've got to monitor blood sugar,
That's what I think right away as well. What's the patient's blood sugar? Oh, and they're a diabetic too. So I know I'm going to be doing blood sugars, at least looking at the lab value to monitor that because of the steroid treatment. Vancomycin, hard on the kidneys, good gosh, and they already told me he's here for AKI, so what's the gig with that, right? Lisinopril for his blood pressure. NAB treatments, okay, he's got COPD, and here's his insulin coverage. How does he manage his diabetes at home? I don't know yet. All right, so I have a few more questions than anything else, right, at this point in time. So I go and do my assessment. The patient's got a fever. Pulse is 87, not great, but not bad if you've got a fever, can understand that. Respiratory rate 22, all right, COPD here with pneumonia. Not great, but not horrible. Blood pressure is 102 over 68.
That's low.
That's low, I'm not too happy with that, right? Because he has a history of hypertension too. Stats 95%, that's great, blood on 2 liters. So that kind of tells me maybe he doesn't wear oxygen at home because, I don't know, yes. Appears to be resting comfortably. Rest sounds are clear in the upper lobes, diminished in the basis. Dyspneic on exertion, well, that could be his baseline, not really sure yet, right? I'd have to ask. Non-labored at rest. So I'm happy with that, because worst case scenario is don't move at this point, right? Until I get to know the patient and the whole scenario, I want to make sure that they're safe. Cardiac-wise, colors pink, warm, dry, S1, S2, those are your normal heart sounds. He's got some edema in his lower extremities, but good pulses. All right, so is it always there? Is it not? Is this something new? Alert and oriented, moves all extremities, but is weak. Well, I kind of expect him to be weak, because why? He's got an infection, and so COPD doesn't really make you weak, it makes you short of breath.
What about his age?
He's what?
His age?
His age, he's 84, right? So I kind of expect him to be weak with an infection, not surprised. GI is all good, and his urine's cloudy, has some sediment, and his output for the last 8 hours is 150. So what does that equal an hour?
9 to 20. Less than 20.
Less than 20 an hour. So this probably equates to polyuria, right? If I had to put a name on it. Right, it's not anuria, he's avoiding, it's definitely not poly. All right, blood sugar, well, better, but it is elevated, but he is diabetic and he is sick, so, okay. Sodium within normal, potassium, now he's at the high end and trending up, a little concerning, right? Phosphorus definitely has increased, the calcium came down a little. The BUN has increased, right? Blood, urea, nitrogen, right? So what is that from? Multi things an elevated BUN could mean, right? Your gut breaks down protein, sends it to the liver. The byproduct is urea. Liver sends urea in the blood to the kidneys, and the kidneys need to excrete it. So yes, it's an indication of kidney function, but it can also be an indication of your liver too. It can also be an indication of your hydration status. So while these BUN, creatinines, and GFRs are all great, the BUN is really your least indicated predictor because it can mean other things. Creatinine, we know creatinine is specific to the kidney, 1.8 to 2.6. Not so great with that, right? GFR, 42 down to 25. So that's your filtration rate. How much can it filter in a minute? Our white count, 18 to 14. H&H, 11 and 34, came down, 9 and 29. What are your thoughts on that?
No.
Because of the hydration, so we're gonna see that drop. Maybe he came in, he was dehydrated, gets a liter of fluid. You come in, it's hemo concentrated, your H&H is gonna be falsely elevated, give some fluids, and now your H&H decreases. If it stays there, you know it was hydration. If it continues to drop, now what am I worried about? Some kind of bleeding. Yes? Okay. And platelets. So now I ask you, and you might want to leave your case, those first 2 pages up so you can look at those and then look at the screen to see how you would answer these questions. In next gen NCLEX, or even on our exams in the future, not next Monday, just to be clear, you would have the case on one side and the question right next to it. So that way there you can see the case and see the question. There might be little tabs, like a chart. Maybe it's vital signs, past medical history, labs, so it's very real world, and you would need to be able to go into the different tabs to assess the information. So here's your first question. Select all that apply, and you're gonna identify 4. Your top 4 concerns. It's a minute.
Oh, okay.
Not the party, it's not his blood pressure, it's not the glucose, it's not his white blood cell count because that's right. It's not
But like, well, the only reason I said no is because he definitely has one.
All right, so is your heart rate a concern? No, it's what, 87? The blood pressure? Yes. 12. The glucose?
Not right now.
Okay, and it was what?
185.
185. Creatinine? Why? Elevated, it's going the wrong direction. White blood cells?
Not really.
They're trending down, so we're actually good with that, right? Potassium?
Yes.
Yes, why?
It's trending up.
It's trending up, okay. Is everybody, okay. But it's still normal. Oh, we have somebody who says no. It's not as important as the urine output in GFR, she's saying. So what about the urine output?
For sure.
For sure. GFR?
For sure.
For sure. Edema?
No.
No, not really. So we have too many. Which one are you getting rid of?
Blood pressure.
blood pressure.
Potassium. Why are you getting rid of the potassium? Because right now it's normal. It's the high end of normal. Yes, we're monitoring, but it's not our top concern. Okay? want me to highlight the labs?
Well, I was just wondering what you would highlight if you saw this.
Okay, well, the glucose is coming down, so even though it's elevated, I'm thinking the patient's diabetic and I'm not gonna highlight it. Yes, I would monitor it, but it doesn't, no bells go off, right? Like, oh my gosh. Sodium. Now, if it was swinging the other way, then that might be different, right? The sodium is within normal limits, the potassium, it's on the high side, but it's still within normal limits, so I am gonna continue to monitor that. Phosphorus is normal, the calcium is normal, low end, right, reciprocal of phosphorus, so we'll kind of expect that. The BUN is going the wrong way, so I'm definitely highlighting that. And my creatinine, so I'm looking for things that are worse.
I don't know.
Right? Doesn't mean that I'm not gonna pay attention to my potassium and my glucose, because I am. But if I go to this question and I only have 4 things that I can pick, if something's within normal range, I'm not picking it. Right? Because I would continue to monitor that at this point.
Thank you.
Is that helpful?
Yeah.
Okay. Identify which cause is consistent with which type of acute kidney injury. Here we go, right? So let's do this together. Decreased cardiac output.
Pre-renal.
Pre-renal. Mechanical outflow obstruction. Post. Prostate cancer.
Post.
Tubular obstruction by myoglobin. Intra. Tubular. Okay. Hypovolemia.
Pre.
Nephrotoxic medications. Intra. What are some examples of nephrotoxic medications? NSAIDs, vancomycin, anti-inflammatories, Zoloft or Toradol. Yes, that goes along with that NSAIDs category. Your aminoglycosides, your gentamicin, your vancomycin, hemodrugs, amphotericin B, that's really another nasty antibiotic. What else do we administer to patients? Well, we don't usually, it's down in a radiology. Contrast dye. Big star next to those, right? Because we see nephrotoxic, most common is our hypovolemia and our nephrotoxic things, like the gentamicin, the vancomycin, and contrast dyes. We see that the most. Those are the most common. There was a comment or question up in the back.
Oh, no, I was just gonna answer the question.
Okay. Bladder cancer. Toast. Sepsis. Pre. Acute glomerular nephritis. Intra. So not difficult to see where it's coming from, right? Yeah, it is. I'm sorry. All right, here's a fill in the blank. A nurse identifies the priority concern the client is experiencing is, and you have to pick something from this option 1 column. Now, if I had the ability, I could do a drop down here where I could click the arrow and select right there. As evidenced by blank and blank. So let me give you a few minutes and see if we can put this together.
identifies the is experienced weight
Okay,
Yeah.
so let's pull it back in. What do you guys think is the client is experiencing? AKI as evidenced by creatinine and urine output. Fluid volume excess, does your patient have fluid volume excess? How do we know the patient has fluid volume excess?
High blood pressure.
Doesn't have a high H&H anymore, it's low, and it never was really high.
Yeah, blood pressure.
So if you have fluid volume excess, what are some symptoms that you're gonna see in your patient? Your blood pressure is gonna be elevated. Is our patient's blood pressure elevated? No. Yes, he does have some edema, but why? We don't really know, but it's definitely not related. He had true volume excess. He could have low albumin. He is 84. Might be his baseline. That's okay. You would be tachycardic. You potentially could have some crackles in the lungs, some JVD. Does he have all that? No. So he's not in fluid volume excess. Even though you have the option for edema. But when we keep going, heart rate, does that show fluid volume excess in him, for him? No. Does his blood pressure show it? No. His blood sugar, not even related to that. And urine output, definitely not. Hyperglycemia, we could go down that path, right? What matches that? That dry skin, high and dry, not so much flaky, but dry. And as evidenced by the blood sugar, 185.
Is it priority?
But is it the priority? No. Electrolyte imbalance, well, you could say the potassium level, but it's only 5.1, yes, high in the norm, we're gonna monitor it, it's not the priority. And then there's nothing else that matches that with here. There's no EKG changes or anything like that. Okay? Good?
I have a question.
Sure.
It was pointed out on the lab values, it has the GFR at a normal range of over 60. But it
Yes.
says over 90 in our PowerPoint, is that?
So you're going to see a lot of different numbers. Normal is anywhere from 90 to 120. Depending on the reference that you use or the lab, most of the labs in the hospital are going to be greater than 60.
Okay.
Like,
But for the exam, we're going 90 over 90,
do you need to know lab values? Do we give you lab values now? Yeah. Yes, why? Because they're on N+. Okay. Should you have a general understanding of where those lab values are, the basics? Yes. Sorry. CV, I don't know why I did that. Okay, next question. Which data will the nurse assess to determine the phase of AKI? So what is it that we assess to know which phase that they're in? Polyuric, diuretic? Sure.
I added blood pressure because I thought since my blood pressure was on the low end, that it might have just like the sign
Of AKI?
well, I was thinking like not dehydration, but
Low volume.
That's why I added that.
I can see why you would pick good blood pressure, but urine output is a better indicator because it's polyuric, how much urine is putting out, right? For all we know, he could be septic with a pneumonia, I don't know. All right, so which data are we going to assess to determine the phase of AKI? So let's start at the top. BUN?
Yes.
Yes. Okay. Creatinine?
Yes.
Yes. Urine output?
Yes.
GFR?
Yes.
Yes. I thought I heard a no in there, but it's yes. Glucose?
No.
No. Specific gravity?
Yes.
Potassium?
Yes.
Blood pressure? It does give you a good indication. I would use the blood pressure. All right, so our BUN, I'm going to write this right in the middle. BUN, creatinine, the GFR. Oh, urine output. And I'll put vital signs and potassium. I have urine output, UA, specific gravity. Okay? We're coming back to that. The nurse begins to plan care for the patient. For each order, specify whether the order is appropriate or not appropriate in the plan of care. All right, so think about our patient. We're still talking about the same patient. Normal saline at 100.
Yes.
Yes, we want them to have fluids. We don't have enough in the tank, right? I know.
Yes.
Calcium glutamate, 10% IV.
No.
What's that used for?
Potassium.
Really high potassium, the patient who has an elevated potassium who's got some EKG changes. So calcium glutamate is a cardioprotective. If you start the patient on a cardiac monitor, we see changes, potassium's elevated, we can administer calcium glutamate to kind of decrease that threshold, prevent them from having any kind of arrhythmias. Now that just decreases the threshold. It doesn't get rid of the potassium. We still have to fix the problem, which would be how do we change that potassium level? Kxalate or insulin glucose. Okay? So not appropriate right now. Furosemide? No. If your patient needs it. Otherwise, we're not just going to give a diuretic to lower the potassium, right? We're indicating the diuretic if they have too much fluid on board, right? Not because of solely the potassium is too high. Fluid restriction? No. Administering potassium? No. Big fat? Lisinopril? So the order's appropriate. Right now, we would be holding it, right? We have parameters. So it is an appropriate order, even though, not so friendly to the kidneys, those ACE inhibitors. Maybe their dose would be modified, maybe they would change the medications. But we do want to make sure that it doesn't fall off as far as med reconciliation. It doesn't, when he stabilizes, go back on his antihypertensive med.
Now, his blood pressure is over 100, so we'd still be able to pay.
What's his blood pressure? 102.
Wouldn't that
So
be
do
like,
you-
like clinical judgment though? Like some nurses
Yeah.
would give it and some nurses wouldn't
Right.
because it's so close to the
So close.
parameters.
Parameters.
Yeah.
So if it's within how much of the parameter, or is it based on other symptoms that you're seeing?
The whole picture, right?
Okay.
And you can hold a medication at any time. What you need to know is, why am I holding that medication? What am I gonna do about it? Does it have to be administered right now or not? A BID medication, can that wait? Yes, that can wait. Can I have a conversation with the provider about it? Absolutely.
Thank you.
So, but we're gonna put appropriate for this question or any question. Because they're not asking about, clinical judgment or anything like that, they're asking yes or no.
They are asking yes or no. He does have a history of hypertension. So I would say it's appropriate.
For the whole,
For the test.
That the patient needs, that this order is appropriate for this patient.
okay.
I can understand what you're saying. 3,
No,
right?
but because it says told, if it's greater than 100.
Less than.
All right, I'm gonna go drink my coffee.
All right, vancomycin, 1 gram, peak and trough on third dose.
Not appropriate.
Not appropriate?
That's for infection.
It's appropriate.
It is.
Why is it appropriate?
The doctor ordered it and that's
Even though it's nephrotoxic,
Can't we give them like 17 or something?
perhaps, I'm thinking there's a reason why they ordered vancomycin. It was on those original orders, right? Can we question it? Yes. Is it appropriate? Is it appropriate? Yes, because of the peak and trough. We're going to monitor what that medication is doing to the kidneys. So what do we know about peak and troughs? This is a must know. So there's some kind of method. Each hospital's a little bit different. It's somewhere between the first, third, and fifth dose, every third to fifth dose, that you're going to be checking the levels. We want the peak and the trough. So the trough is how much is in the blood right now of that medication. You check the trough prior to giving the medication. Can't administer the med without the trough. You have to wait for the results to come back. You have to wait. So your plan of administering that med exactly at this time, not gonna happen. Right? Because you have to wait for the trough. If the trough is too high, what are we gonna do?
Hold it.
We're gonna hold it, we're gonna contact, most of the time, the pharmacy that's actually doing this now, not the provider. The pharmacy takes this over and adjusts the dosing. So based on that level, we can, yes, we're gonna hold it for now. They may decrease the dose or lengthen the time frame. So the Vanco right now is every 8 hours. Maybe they change it to every 12 hours. Okay? Maybe the 1 gram now goes to 750 milligrams every 12 hours. And we're gonna, yes, monitor our BUN and creatinine and GFR throughout each day, normal labs that we're checking. But prior to administering the dose, on that third dose, they're gonna check that trough again. Now, if it doesn't come up in the MAR, if it doesn't pop up in a box to make sure that you do this at this time because maybe the lab wasn't put in or it didn't trigger right, before you give that Vanco, you have to, must, guaranteed, star, highlight, go back and see when was that last trough. You know how many people ended up in chronic kidney disease from nephrotoxic because troughs weren't checked? That's disgraceful, terrible, no reason for it. No reason for it.
So we're more worried about the pneumonia than the kidney at this point.
We can adjust those nephrotoxic medications to treat the patient safely if they require an immunoglycoside, if they require a vancomycin, if they require chemotherapy, if they require amphotericin B, if they require a contrast dye. Doesn't mean you don't get it. It means we need to do something about it.
In this situation, would you talk to the provider before you gave it about other options besides vancomycin or a glycoside?
I can voice my concern. I'm not the person who administering orders the medications. So I can certainly say, I noticed, I'm concerned about the vancomycin. Is this the best option for this patient? Because I noticed the BUN, creatinine, and GFR since admission have gone from this to this. Urine output is now this. He has symptoms of this.
Okay.
Right? So it's that risk versus benefit. trough level. Now, the peak would be 1 hour after the completion of the medication. It used to be standard that we always did peak and trough, or troughs and peak, I guess I should say the other way, because the trough is before the medication, it's what's maintained in your blood, and the peak would be after. We really don't do peak levels anymore, it's more trough levels, looking at that. And it can vary between 3 to 5 doses. Now this patient, because of his BUN and creatinine, it should be 3 doses, right? I wouldn't feel comfortable if it was 5. Must know about trough levels. You look it up in your nursing book, and I don't know why it's not in there. It's like this huge issue that I have.
So for example, this person doing Q8 hours or 3 times a day. So would that be done like in the morning? Like
No,
before work?
whatever it is. So if you started that medication at noon, then it's at what, 8, then it's at what, 4 a.m., we would draw it prior to that 3rd dose at 4 a.m. It's whenever the dose is due. Has nothing to do with your standard labs. It's almost like the same concept of your heparin therapeutic levels, right? We do it 6 hours until it's good, and then it's once a day for heparin. Well, this is around the dose, specific time to the dose. All right?
But it's only done once a day, right?
It's never done once a day. It is done to the dose.
Yeah,
So-
but if they
So it's done every
once a
3rd
day,
dose, or is it done after the 3rd dose?
It's done before. the
No, I know
dose.
before the 3rd dose, but I'm saying like, is it done, so before the 3rd dose you do it, then like the next time the med is due, do we do it again, or do we wait 3 more
No,
doses?
3 more doses.
Okay, so every 3 doses,
Yeah.
every 3 to 5.
3 to 5 doses. So
Okay.
they may say on the 5th dose, they may say, but it's never usually before the 3rd dose.
Right.
So you can
But you
question
wanna
it.
get
If
it
you're not
in.
liking what the normal lab values are, you can say, hey, he's due for the Vanco. He's had 3 doses. You know, what are your thoughts on a repeat Vanco trough level?
Is it only Vanco we're doing this with?
Vanco and gentamicin. Vanco and gentamicin. Guarantee, go to clinical, you have a gentamicin, vancomycin protocol at your facility. Has anybody seen it? One. Okay, 2, 3, so it's 3 before. On the 3rd dose, so start level before the 3rd dose. So this patient receives 2 doses. Prior to you connecting that 3rd dose, you need to draw blood work and check the trough. Wait for the results. If the trough level is high, then the pharmacy is going to adjust the dose. That 1 gram isn't going to be 1 gram. Or maybe they say, we want you to do it every 12 hours now instead. So they can either spread out the time or adjust the amount. Now we're going to go 2 more doses on the 3rd dose. Again, do the trough. All right. So where does it get screwed up in our system? Well, if the algorithm doesn't automatically happen, then what ends up happening is somebody schedules 3 doses out. Oh, a Vanco trough is due at 4 a.m. on tomorrow's dose, right? But now pharmacy changed it, now it's every 12 hours. So now it's all mixed up, right? The times, does it correlate with what we're continuing now? How many out did they book? Is everybody looking at it? When I go to administer this medication, when was the last trough level? And what is my patient's BUN and creatinine? We know most patients get daily labs every day, right? 6, 7 a.m., depending on your facility. Are you looking at that BUN and creatinine? If it's creeping up, and your provider ordered vancomycin trough level on the 5th dose, well, guess what? I'm calling and saying, hey, I've got a concern about my patient and their safety of their kidneys. I'm vancomycin, and I've noticed the last day from yesterday, BUN and creatinine and GFR have changed for the worse. They've declined, and we're not doing a trough dose on his Vanco until the 5th one. I'm on dose 3 now. What are your thoughts on getting a trough level now? Is that reasonable? Right? Yes? Questions?
So when you take the order to change it from, let's say, every 24 hours, you could go a step further and schedule out the 12 hours.
Make a note on it, yeah. And when you're given a report, I usually say they had their trough, they're due. No different than heparin. You're gonna fry kidneys. I can't tell you how many I've seen. Terrible. You got a question or a comment?
So by on the third dose, you mean before the third dose?
Correct.
Okay.
Okay, continuous cardiac monitor.
Yeah.
Why is that appropriate for him? Potassium is right on the edge. He's on oxygen, has COPD. I can monitor his stats. He's older. All right, the case continues. He's complaining of fatigue, nausea, no appetite. Appears to have an increase in his work of breathing. Great. Lung sounds have crackles in the bases. Lower extremity edema is a little bit worse. He's afebrile. Blood pressure 132 over 84. Heart rate's 112. Respiratory rate 28. His O2 stats are 92%. Now he's what? Overload. Based on the client's reassessment, what are the priority actions? Select all that apply. Place the patient in a high power position? Yes. I hope we're going to set him up, right? Administer a diuretic?
Yes.
It's got too much fluid now, right? Restrict PO fluids? Okay. Encourage potassium-rich fluids? Fluids? No, his potassium's like 5.1, so I don't need to do that. In fact, I'm happy I'm giving the diuretic. Is he going to need a replacement? No. Probably not, right? Administer a bolus of fluids? No, definitely not. Increase the oxygen?
I have a question about that.
Sure.
He has COPD, correct?
He has COPD.
So
She's going there. She is going there. Oh my gosh. What do we do about COPD and oxygen?
Air traffic.
Do not discriminate. Always, always, always oxygenate. You can always turn it down.
is 92.
Okay. So what are our orders? Again, I don't know if our orders, we can go back. I'll play devil's advocate. Does it say greater than 93%? I don't know. I'll give you that. Do we know that our stats are typically lower? Yes, with COPD. Are we okay with the 92%? I guess so, but what other symptoms does he have? He's really short of breath, right? So let's give him some oxygen, let the diuretic work, and then we'll turn it back down to 2. And he was 95. Okay?
I mean, there are
Never discriminate, always put it on. All right, so now we advance to the recovery phase. And we provide discharge teaching regarding health promotion to prevent a reoccurrence. So we saved them, everything's great, right? Select the topic, if it'll be indicated or not indicated. Are we gonna teach them about nephrotoxic meds?
Yeah.
Yeah, we don't want them taking some NSAIDs or anything like that, right? Diet high in protein? Absolutely not. If anything, it should be low in protein, right? And if he's recovered, then we don't need to worry about this diet right now. It's when they're actually in that AKI, when we might implement all these dietary changes. Now, your recovery phase can last a long time. So if his levels aren't normal yet, he might have some dietary restrictions. But it certainly isn't high in protein. It'd be the complete opposite. It'd be low in protein, high carbs. Preventing infections? Yes, always. certainly for the AKI. Fluid restriction? No, what do we want? We want our patients hydrated, no matter who you are, well, for the most part, right? So we want that adequate input and output. In management of diabetes? Yes, absolutely. Health fat prevention, that's one of our risk factors. Okay. So the case is gonna continue. He's afebrile, pulse is 70, blood pressure 126 over 76. He's 94 on room air, look at that. Okay, he's resting comfortably. Lungs are good. He's got some mild dyspnea on exertion, non-labored at rest. What do we think that might be related to? COPD. His skin's warm and dry. He still has this edema. What's that all about? Alert and oriented, moves all extremities. He's weak. What do we think? He's 84. He's been sick. He's been in the hospital. Okay. GI is good. GU, clear yellow urine, no sediment. Output for last 8 hours is 500. All right. Good, right?
He is ready for discharge.
He is ready.
I know.
We got another patient that we wait to come up. So the glucose is 225. And 5. Sodium 138. Potassium 4.5. Phosphorus 4. Calcium 9. BUN 23.
Better.
Still elevated, but still better.
It's an improvement.
It's improvement. Creatinine 1.4. GFR 50.
Better.
It's
trending up.
Is it better? It's going the right way. White count 9. HH 1030. And platelets 232. Okay, so here's the last question in that case of NGN where you have to evaluate your patient. So look how we read through that and we're making those decisions of how the patient's doing, analyzing whether it worked, didn't work, where they're at right now. We kind of went through each of those things. So for the blood pressure, was it improved, declined, or unchanged? Improved. Creatinine? Improved. Potassium? Potassium? Unchanged. It's been within normal limits the whole time. It's been within normal limits the whole time.
So with
Let's
normal,
go back
within
right
normal
here.
limits, it's not considered a change if it goes from 3.5 to 5.1.
It's still all within normal limits. We came in at 4.2,
Okay.
right? So it's unchanged. Urine output? Improved. Glucose? Declined. GFR? Improved. Edema? Unchanged. Okay? Go ahead.
So for his glucose, because it's the only thing
For what?
His glucose, because that's the only thing that declined, does that mean that the nurse should probably implement more teaching?
And what do we think is going on with glucose? The steroids. Right? And again, we don't have that information. Does he check his sugar at home? Does he take insulin?
Okay.
When is that glucose going to become better?
Once he's done.
Once we decrease those steroids. Okay? All right. Hey, now we're done with the case. We're done with the case. We can draw a line there. The nurse, because I want to go back to this phase stuff, okay? The nurse evaluates this specific data. It's not related to the case. We're taking these things independently to determine the phase of AKI. Which data correlates with either the oliguric or the diuretic phase. So potassium level of 2.5. Diuretic. High Why? Because your urine is concentrated, it's heavy, high specific gravity. Okay? Urine output of 300 a day. Polyuria. Think of the name, polyuria. Polyuria, anuria. Hyperkalemia. Poly. Urine output of 5. Diuretic. Elevated blood pressure, heart rate. Elevated. Ollie. Why? Because you're holding on to the fluid. The big difference between these phases, right? Your BUN is increased, your creatinine is increased, your GFR. Your urine output is down. Your specific gravity is heavy, that urine. Okay, so that's elevated. Your vital signs. Well, your heart rate for both of them may be up. But what's the big difference in that blood pressure? Why? You're holding on to fluid. We can't get it out. Kidneys aren't taking it out. It's still in the system. We're peeing it out. We're getting high urine output here. High. Diuretic phase, high urine. When I lose all that fluid, what's going to happen to my blood pressure? Drop down. It's going to drop down. I'm going to have signs and symptoms of dehydration. Diuretic. What's going to happen to my potassium if I'm losing all this fluid? It's going to go down. If I'm holding on to it, what's going to happen here? It's going to go up. Yes?
Yes.
Do patients always go through these phases? No. Do they have to be allier? No, they could have urine output that's maybe a little bit less, not by definition of allier. Pearson does it. Their phases are different. Please don't use those phases because that's not common. What they have is it onset, maintenance. They consider both of these maintenance. I don't know why, or maybe they consider this the recovery. But there's actually 4 phases. The onset, where maybe they just have some abnormal lab values, and now they start getting symptoms. Are they oliguric? Where they have a fluid volume excess, or are they diuretic, where they're fluid volume deficit, because they're diuresing. The kidneys, the tubules, the nephrons, they're working. They can filter the blood, but there's like holes, so it's going in and out, and they're just dumping stuff. They can't concentrate the urine. So this is a good thing that they're progressing, but not so good, right, that they can't concentrate the urine. So we still have fluid balance issues and electrolyte issues. Very different, very, very different, treatment-wise, and what we see in symptoms. All right, what do you do if a BUN creatinine are elevated and that for any patient and the GFR is decreased? Fluid. Before you jump to the interventions, how about we keep assessing the patient? So we will check their vital signs. A daily weight, that's interventions. What else are you going to assess? Urine output gives us so much information, right? So our vital signs, our urine output, other electrolytes. What else do you want to know about the patient? Their history, why? Get their baseline. Maybe they've got a history of chronic kidney disease and this is their normal. And we're jumping to fluids. You don't have to jump ahead. Slow it back. Finish your assessment. Is the patient getting anything nephrotoxic that's causing them? All right, what do you do if a patient has a CAT scan ordered with contrast? Any patient, any single patient that you have.
I'll check, I'll be.
Check your kidney function. What's that? BUN, creatinine, GFR. Happy little family. It does. All right? Any patient who goes for a CAT scan with contrast, you're checking that before they go. If it's elevated, what are you going to do? Talk to the provider. What are you going to say? Is it necessary to do the contrast because I'm concerned about the patient's safety with their kidneys? I noticed that the BUN, creatinine, what that is. Yes, they need the contrast. Now what? Find another provider? Find another nurse? Find another nurse? No. What can we do to protect the kidneys? This is another must know. Because what do we say? The most common is this nephrotoxic and the hypovolemic, right? So we talked about at length gentamicin, vancomycin. Contrast dyes are huge. So maybe they need some hydration, right? So we can wash that out. There's nephro-safe contrast dyes. So when we're looking at the different contrast dyes, we want one that's safe for the kidneys. We can hydrate the patient. Maybe the patient needs some fluids prior to the test and after. What else can you do? There's one more big thing. We can protect those kidneys how?
Buffering agent.
A buffering agent, okay? Acetylcysteine, mucomist. All right, protect those kidneys. What must the nurse assess after the next day from that CAT scan?
GFR.
The BUN, creatinine, GFR. Okay? And what if you have a aminoglycoside antibiotic? Make sure the trough level is done. We talked at length about that. Okay? Good? Feel better about AKI? Applying into the patient? Question in the back. Hold on, we're almost done. Oh, metformin. Thank you. So you do, was it just a comment that you were making or?
Yeah, it's just.
No, thank you for bringing that up. So metformin, what we have to do with metformin CAT scans, because it can increase your chance of nephrotoxicity. So you have to hold the metformin. Many times it's for 48 hours. Some institutions, anytime that you're on metformin, when you come into the hospital, they take you off it and put you on insulin sliding because, again, why? Risk versus benefit. They want to eliminate that potential cause. That's one of the reasons why. They can control that sugar a little better. Thank you on that one. That one is very important.
So that's just with the contract?
Got it. Okay? Take a break.
No.
If you have questions, let me know.
Risk factors, diagnostic tests, very similar or the same as what you do with AKI, and clinical manifestations of chronic kidney disease. But it's again, think of it as a continuum. It's a progressive disease. So there's not just one set of symptoms or one set of lab values, right? Because it gets progressively worse and it's actually staged. So chronic kidney disease staging is based on the glomerular filtration rate. So that is the rate that the nephrons are filtering, they're working. And as you know, as you learn, as you lose, as someone's losing their ability to filtrate and their nephrons aren't functioning, their GFR is going to decline. So staging chronic kidney disease is stage 1 through 5. Stage 5 is also end-stage renal disease. That's what the ESRD is. Okay? So it is based on the GFR, not the creatinine, not the UN. But GFR is the best estimate or best evaluation of total kidney function. Because it doesn't just take one lab value or one parameter, it's a formula for that patient. It uses their creatinine level, their age, their weight, their gender. So it's the GFR. You'll also see an E in front of it, estimated GFR. It's recorded in milliliters per minute per 1.73 meters squared. But I kind of left that part off because usually we just say GFR is 90, whatever. But when you see it in a lab value, you'll see that. So stage 1. Well, first of all, what's the normal GFR?
Over 90.
Over 90, good. 100, 120 for real healthy kidneys. Normal is over 90. So stage 1 is when there's some renal impairment, but the GFR is 90 or greater, and they're asymptomatic. But they have some nephrons, have some chronic disease with the nephrons, okay? So big difference between AKI and CKD is CKD is not reversible, right? Acute kidney injury is reversible with treatment. If it's untreated, it can decompensate or lead to chronic kidney disease, yes?
So it says stage 1 is asymptomatic, normal GFR, normal BUN.
Yeah, it might be a little low, so we don't even know, like looking at someone or from their labs, you can't tell that they have
So are we
nephrons.
all in stage 1?
No,
I mean, so what's the indicator that there's a difference between stage 1 and totally fine?
your nephrons aren't working.
Okay.
So maybe I have nephrons not working, but my GFR is still greater than 90.
Okay.
Okay, so totally healthy, no chronic kidney diseases. You have no, all your nephrons are filtrating, normally.
How do you know if the nephrons are working or not?
By the GFR.
But if the GFR
So
is fine.
okay, but
I'm just
remember, it's progressive, right?
Yeah, yeah.
So, I go to the doctor, I get my checkup, wow, your GFR is 30. Am I gonna diagnose you with CKD? No, it takes 3 months, right? It's over a 3-month period that your GFR is low or drops more than 15 in a year or something. It's not just based on one lab value, right? So it has to start somewhere, right?
Yeah, yeah.
So
if
that's
I'm
why.
normally like 120, but then now I'm like at 95, then you probably have some CKD, but you're now.
Maybe,
you're not
but you don't ever look at one thing, right?
Okay,
So
yeah.
remember, our biggest risk factors for renal disease is what? What's our biggest risk factors? What does it say on my slides? Diabetes and hypertension, right? Diabetes, hypertension. And then lots of different intrarenal diseases that they can have. Normal aging, a lot of contributing factors. So stage 2 is a GFR of 60 to 89, where there's a mild decrease in GFR, and they probably have some, elevated BUN creatinine, but probably asymptomatic, and may have some hypertension. Again, probably largely undetected unless someone's getting a workup. And again, it's not a one-time GFR. Stage 3 is a GFR of 30 to 59 milliliters per minute, where there's a moderate decrease in the glomerular filtration rate. And the patient now is starting to exhibit some of those signs of CKD, anemia, fatigue, anorexia, elevated BUN and creatinine, and now they're starting to just pay more attention, maybe make some lifestyle and dietary changes, and knowing that diabetes and hypertension can cause it and increase risk. What do you think would be part of the treatment plan and part of nursing educated?
Regulating your sugar level.
Good. your diabetes, to keep that glucose at normal level, managing your hypertension, right? And then stage 4 is the GFR, 15 to 29. At this point, the glomerular filtration rate is severely decreased. So as the GFR goes down, what's increasing? Our BUN, our creatinine, now our electrolytes, our potassium, our phosphorus, metabolic acidosis may be present because do our kidneys help regulate acid-base balance? Yes. So now more symptomatic, they may need medication to treat stage 4, dietary changes or limits in their diet, which we're going to talk about with treatment. And really the goal is to prevent it from progressing to the next stage and needing hemodialysis, peritoneal dialysis, or a kidney transplant. So the whole goal of all the treatment for chronic kidney disease is to try to prevent or slow the progression of the disease, right? And prevent complications of the disease. And then stage 5 is that end stage renal disease where the GFR is less than 15 and all, they're very uremic, lots of abnormal symptoms. There's 2 slides with symptoms that you can see on my side, right? And it's multi-system. It's affecting the skin, the heart, the bones, neurologic, cognitive, right? It affects everything. And at this point, they're going to need a renal replacement treatment. So we're going to talk about that with our treatments. So once again, having a good understanding of what the kidneys do, which I know we reviewed, we talked about AKI. As I've been saying since the beginning of the year, whenever you start a new system and learning the pathophysiology, the diseases, and the nursing management of, if you need a refresher in that body system, I find that extremely helpful. So go back and review what do the kidneys do, because then it's going to all make sense what your symptoms are, right? What your abnormal symptoms are. So if you need a review on what do the kidneys do with the body, because then it just clicks. What are our symptoms? What is our treatment? So we're going to start on slide 10, the treatment, which with patients with chronic kidney disease is a very collaborative effort. It involves the nephrologist. Usually the nephrologist is consulted when someone's in stage 3 or definitely stage 4. So the general practitioner may be monitoring the patient's GFR and kidney function, right? But then when they're at stage 3 and their GFR continues to drop over the year, then at that point they're going to consult a nephrologist for more specialized care. A nutritionist, because there are some dietary limitations or changes to help manage it. Case manager, especially if they're going to be needing some dialysis, whether it's peritoneal or chemo. Social worker, a physical therapist, home care services, and again, if they're on dialysis, they're going to develop a relationship with the company and the dialysis nurses and staff.
I have a question. If they have diabetes, will they be followed by an endocrinologist too?
Yes, yeah, we know we have patients that have multiple different specialists, right? An endocrinologist, a cardiologist, a nephrologist, a pulmonologist, infectious disease, and a general practitioner. You may also have, today, nowadays there's so many specialists, it's very common for people with comorbidities to have multiple doctors following them, and they each kind of focus on their specific area, right? So again, our treatment goals are to prevent progression of chronic kidney disease. So do you think early detection is important? Early detection and early prevention to prevent it from getting to the point where they are severely compromised, have uremia, and need renal replacement. And to monitor for complications and manage complications if they're at that late stage chronic kidney disease. So how do we treat them initially in the early stages? with dietary changes, pharmacological agents or drugs or medication, whatever term you want, fluid management, again, think about what the kidneys do. So if you need to go back and review your A&P on the kidneys, because now you know what the treatment's gonna be. If your kidneys are not functioning properly, well, we know our kidneys help regulate our blood pressure. They help regulate our fluid balance. They secrete erythropoietin for red blood cells. They have acid-base balance, potassium balance, phosphate balance, right? So if your kidneys aren't working, all those things are gonna be abnormal. So that's what I mean by review your A&P, know really intimately what the kidneys do. Now you know what the clinical manifestations are and what the treatments are gonna be. So early stages, they're just monitored in stage 1 and 2. Talked about healthy lifestyle, drinking fluids, exercise, manage your weight. If you have hypertension or diabetes, manage that. Try to slow the progression. Stage 3, if there's any abnormal labs, God bless you, they can correct them with dietary changes and medications. Stage 4, again, everyone's an individual. So if we have 4 people in stage 3 chronic kidney disease, they're not going to be all on the exact medications and doses. It's based on their lab values. So if they have an increased phosphate level, they'll be on a low phosphorus diet. If they have a high potassium, they'll be on a limited potassium diet. When they're in stage 4, now they're starting to think, we better think about what renal replacement treatment we're going to use when the kidneys, if and when the kidneys progress to end-stage renal failure. The patient won't live if they're both, if they're in end-stage renal failure. We're going to have to do the job of the kidneys. And that's either hemodialysis, peritoneal dialysis, and or kidney transplant. Okay? So stage 5, ESRD, we said end stage, definitely involves a renal replacement therapy. So pharmacological treatment, again, is aimed at treating the electrolyte imbalances and replacing things like the vitamin D and erythropoietin to treat the anemia, multivitamins, folic acid and iron supplements. Lipid-lowering agents are usually given because cardiovascular disease goes hand in hand with renal disease. People with renal disease will develop cardiovascular disease, and that's actually the #1 cause of death eventually, is they die of cardiovascular disease. So lipid-lowering agents, managing any hypertension that's present with antihypertensives, ACE inhibitors, and angiotensin II receptor blockers. Phosphate binders to help lower a high phosphate level. So we have a slide on those. Erythropoietin, that's naturally produced in the kidneys, which is necessary for the production of red blood cells. So if the kidneys are not producing erythropoietin, we can administer it exogenously, right? We can give them Epogen sub-Q injections. If they're in metabolic acidosis, they may get sodium bicarbonate. If their potassium level is extremely high, they may treat the high potassium with medications to lower the potassium. What is the concern with hyperkalemia? I know you guys know this. Cardiac dysrhythmias, good. I was like, I know you've heard this throughout the whole year. So, yes?
You said cardiac dysfunction is what usually causes death in these patients? Or
Yes. So all my research said, usually what do patients with end-stage chronic kidney disease die of? Well, some of them get infections and sepsis and die, but the #1 cause is a cardiovascular. So, MI, stroke.
Because Professor Brown before had said it was infection earlier.
Maybe for AKI it is infection.
So this is for end stage?
I'm talking about chronic kidney disease end stage. Yes, They are, especially end stage, we're gonna talk about hemodialysis, peritoneal dialysis, and kidney transplant. So think about this. General concepts is what you gotta take away from your nursing program. Did you learn that if you stick a catheter in anybody or a chronic device, what does it increase the risk of? Infection. Anyone that has an infection can get what? What's the worst complication? Sepsis, septic shock, and die. Now you take someone who's compromised, right? Because they have chronic kidney disease, end-stage renal disease. It's not usually a healthy person in other aspects. They usually have already hypertension, already have cardiovascular disease, already have diabetes. Some people don't. We have some young people that have to get dialysis because maybe they're born with like glomerular nephritis or a kidney disease, right? So there are certainly people in their 30s on peritoneal dialysis and young people because they're born with a kidney disease that causes it. But for the most part, they have a lot of comorbidities, so they're at higher risk for infection. But usually, the more common cause of death is cardiovascular disease. So phosphate binders are given to help decrease hyperphosphatemia. Our kidneys excrete phosphorus. So if the kidneys are not filtering and not functioning, phosphorus is going to build up. Well, who cares about phosphorus, right? Is that something you know of, could rattle off the top of your head? What's the problem with elevated phosphorus? Anybody know any problems?
It takes calcium with it, it binds to calcium, so then calcium is
Right, there's an inverse relationship with calcium and phosphorus. As phosphorus goes up, calcium goes down. So hypocalcemia. Now we worry about muscle function and bone function, right? Good. Phosphorus also will screw up the PTH, parathyroid hormone. Again, our calcium, our vitamin D, which is essential for bone health. So now the high phosphate over time is going to lead to soft bones, osteoporosis, osteomalacia, fractures, and bone disorders. Also vascular calcifications, bone demineralization. So we do have to treat the hyperphosphatemia, and we do that with phosphate binders. They're given with meals. They only work if they're administered with meals. So if your patient misses a dose or doesn't eat their NPO because they're going for surgery, then it doesn't make sense to give them the phosphate binder in the middle of anything. It's given with meals to help bind the phosphorus out of the GI tract when the patient's ingesting the food. It's the most common ones are calcium carbonate and calcium acetate. Those are calcium-based phosphate binders, Oscal and Foslo. And then there's calcium-free ones, which are our Sevelamer, Renvela or Renagel, which though calcium-free ones also have the benefit of decreasing the cholesterol. So they're taken with meals 3 times a day. To treat high phosphorus levels. Did that answer your question?
No, I was talking about that phosphate, is that, those?
No. No, that one, I don't know. What? Phosphate? I don't, is that a calcium? Yeah. And then another drug, again, it's pending if the patient's anemic. How do you know if someone's anemic? Check their hemoglobin and hematocrit, right. So if their hemoglobin's low and they're in late-stage kidney disease, one of the drugs we can use, medications, drugs, pharmacological agent, whatever term you want, is Epogen. Because the kidneys aren't producing that because they're compromised, they're diseased, they have chronic kidney disease, which we said is irreversible. So erythropoietin is a hormone that stimulates red blood cell production and will help treat the low H&H. given subcutaneously. Once the hemoglobin is in the normal range, 10 to 11, then it can be decreased. So again, these are like answering question techniques. If one of your questions is, the patient's on erythropoietin, the patient with CKD is on erythropoietin, what does the nurse need to monitor? Hemoglobin. Good. Right? So those are two common drugs, phosphate binders, erythropoietin, but also all the other drugs we said, antihypertensive, folic acid, iron, those treat anemia, right? We're going to control the blood pressure. If they have diabetes, they're going to be on insulin. They're going to be on lipid-lowering agents if their cholesterol's high. And we also treat with nutritional changes, dietary changes. Again, it's based on what stage of kidney disease they're in and what renal replacement. So I can't say across the board, everyone with CKD is on a low sodium, low cholesterol, low sugar, low potassium diet, right? Because remember, there's stages. Stage 1, 2, and 3, maybe they don't have any dietary changes at this point. The lower end of stage 3, maybe now the nutrition says, I think your potassium and your phosphorus are on the high side. We need to limit those in your diet. So the diet will vary based on what stage they're in and what type of treatment they're getting. But in general, you know that we said there's a problem with elevated potassium, elevated phosphorus. Also, probably when you talk AKI, what's one thing we see with kidney disease? Albumin or protein spilling over in the urine, being secreted out. So their protein, we may need to either limit their protein intake or increase it. Again, they're going to check that urine albumin to creatinine ratio. The protein we do recommend is a high value protein, so eggs, fish, chicken, as opposed to fatty red meats, bacon, beef, and pork. So it's, encouraging the healthy, high value proteins. Oftentimes they have to increase carbs. Again, you got to see what else is going on with the patient. Obviously, if they're also diabetes, then we're going to be careful with carbs. In general, because of the water balance issues, our kidneys help balance water and hypertension. Sodium may be restricted, and we know in general with cardiovascular disease and renal disease, trying to be careful with sodium, because sodium's in a lot of our food, right? So definitely not adding salt to food, but canned soups or the dry packaged soups they're loaded with sodium. So a lot of times people are eating those canned Progressive soup, thinking, oh, it's healthy, I'm eating the beef, vegetable, or the minestrone. But if you look at, it's like 900 milligrams of sodium. So just, watching the sodium. And as well, we said calcium may be low, so maybe calcium supplements. So I put DaVita is, DaVita's the main dialysis company in the state of Connecticut. DaVita has freestanding dialysis centers. DaVita's present in most of the hospitals to do inpatient dialysis. And they're a really good resource, their website for patient teaching. So this, DaVita.com, you should check, especially if you have a patient that you need to do some teaching. But also, this is a link to the dietary recommendations. So again, because some of us have more nutritional knowledge than others, I did want to put a list of what some of the high phosphorus foods are, foods high in phosphorus, and high potassium foods. So you would know again what to educate your patient to avoid or limit. Okay, so the phosphorus foods are dairy products, nuts, seeds, beans, meats, bran, cereals, lentils, beans, dark sodas, bottled teas, they said, colas, many food additives, you gotta read the labels. Many of the food additives for preservative, if it has the word phosphorus or phosphate in it, that increases your. So, you may be teaching to limit some of those. And potassium foods are bananas, potatoes, spinach, oranges and orange juice, avocados, dried fruits, broccoli, and salt substitutes. Salt substitutes, patients with CKD and renal disease should not use salt substitutes. Why do you think that is? It has potassium in it, okay? So, using, because if you're on a low salt diet, you may think, oh, give a salt substitute. No, it's better to use like Mrs. Dash, the natural herbs to season the food, and don't use a salt substitute because it can cause increased potassium level. Again, the diet will depend on what stage they're in, so we're talking, stage 3, stage 4. Once they're on dialysis, they're going to monitor their electrolytes and their albumin or protein level. So usually once they're on dialysis, they don't need to restrict their protein anymore. All right, so if CKD progresses to stage 5 and stage renal disease, and what did we say was the GFR for that? Less than 15, then they're going to need some sort of renal replacement. So when the patient with CKD can no longer be managed with just medications, lifestyle changes, and dietary limitations, and their GFR is less than 15, then they have to go on some other form of renal replacement. So hemodialysis, peritoneal, or kidney transplant. So what in general is dialysis? What's happening? It's a diffusion of molecules across a semi-permeable membrane to remove excess fluid and metabolic waste products. It works by diffusion and osmosis. So if it's hemodialysis, the blood's circulating out of their body into a dialysis machine with a filter and the dialysate solution, and through diffusion and osmosis, it's doing the filtration that the kidneys can no longer perform. With peritoneal dialysis, they're using the peritoneal cavity and the membrane in the peritoneum as the filter from diffusion and osmosis to filter out the toxins, the urine waste products, the electrolytes, and water. So we'll talk a little bit about the different types. So hemodialysis, or HD, like we said, is when the blood is taken out of the patient and circulated through the dialyzer. And then the waste products are removed, and the blood is then returned to the patient. So we need an access site to do that, to circulate the blood out of the body into the dialyzer machine and back. So we know with hemo we need some form of vascular access, which we're going to talk about. Usually it's done 3 days per week. The treatment takes about 4 hours. It can be done at home. That's fairly, in the past 20 years, new and becoming more popular. But they can set up home hemodialysis, which we know the benefit would be the patient now doesn't have to drive to a freestanding clinic. Maybe they don't even drive, they might not be healthy enough, so a family member drives them. They're sitting there for 4 hours. But not everyone can do home dialysis because it's going to depend on their resources, their support. Is their eyesight good? Are they cleanly? Do they have family support? Do they have the dexterity? All the training. But they are more and more doing some home hemodialysis. So they need to have vascular access, and that comes in the form of a temporary catheter or a permanent arterial venous fistula or graft. So we call that AV fistula or AV graft. And again, this is planned out before the patient gets to the point they need it, if there's time to plan. You know, if the patient's been being monitored and there's that decline in their GFR, and the nephrologist is like, okay, I think, you know, within the next 6 months, you're gonna need hemo, they do the access ahead of time, because it takes a few weeks to mature. Now, certainly people come in and need emergent dialysis, so they can have a dialysis catheter placed, or they can have a temporary catheter placed before their AV fistula or shunt is ready or mature enough to be used.
What does that mean, mature?
Mature, it's like a healing. They call it mature. So it's a surgical procedure, and when they go to have surgery, it usually takes a couple weeks for it to, the anastomosis to heal, and it's called mature. But basically, it can't be used right away. It takes a couple weeks. There's another form of dialysis, but it's a continuous, so it's done in a critical care setting. Again, usually for AKI or someone emergently has really critical lab values. It's called CRRT, continuous renal replacement therapy, where it's sort of a 24-hour blood filtration done in a critical care setting. The complications to hemodialysis are infection, anemia. Again, we're sticking something in and out of a vascular access, right? Circulating your blood. So anemia, infection, bleeding, because when the blood is taken out and put through the dialyzer, it's going to clot, so they always have to add heparin. So now if you add heparin to someone's blood, you increase their risk of bleeding. And hepatitis. Hepatitis is a risk and fairly common in dialysis patients. I'm guessing just the infection and exposure, the frequent vascular access. It's much better. They used to pretty much, it used to be a real high risk that they had hepatitis. It has decreased. So over here on the left, we have a picture of the temporary access. It's a catheter put in the subclavian vein, going down. It's just like in the same location as a central venous access device, right? And it's tunneled through the skin with a Dacron cup. And if you remember when we talked about CVAD, the benefit of the tunneling is it has a barrier, it creates a barrier for infection, microorganisms won't migrate, and there's a Dacron cup and it keeps it more secure as the tissues adhere around it. There's 2 ports always, a red port and a blue port, one to remove the blood from the patient, one to put it back in. It has clamps on it, it's a very large catheter. It cannot be used for IVs, IV medication, or anything but dialysis. That's their lifeline for dialysis. So if you have a patient with the catheter, and they don't have IV access, you cannot use that for anything but hemodialysis. And like I said, it's a very thick or wide lumen catheter with 2 lumens, a port where the blood comes out, goes through the machine, it comes back in. Obviously it has clamps. Obviously it has to be maintained with sterile technique. It has a sterile dressing just like the central venous access device. And on the right, we have our long-term vascular access, our arteriovenous fistula or graft. So on the top is the fistula, the A. You see they take the vein and the artery and they anastomose it, sew it together. So there's shunting of arterial blood into the vein. So when we talk about, when we assess it as nurses, feeling the thrill and hearing the bruit, it's that turbulent blood flow because the artery and the vein are connected. That's what you're hearing when you listen, auscultate or bruit, or palpate for the throat. It's that turbulent blood flow through the AV fistula.
And you know, I moved to check that and all that, but I honestly, it's so hard when you touch it that I thought it was some sort of device in there. But it's
Well,
not.
if it's a graft, it could be. So the other type of arteriovenous is the AV graft. So again, it's, you know, we're not picking at the patient, it depends on their veins, their health, other things going on. Because for the most part, these people have other comorbidities, age. So if they can't do the AV fistula, where they anastomose their vein and artery, they'll put an artificial graft in. So you may be feeling that. It will be harder. It's a type of rubber catheter. It's a graft.
So that graft is under the skin?
Oh, it's all under, yes. But you can see it, it's bulging, it's tortuous, it's very visible.
And then they access that through the skin?
Yes, with needles, they access it for each dialysis treatment. Hence, increase of bleeding, increased risk of infection, right? So when they surgically, they have to go to the OR and surgically insert these. You can't use them right away. They have to heal, mature, whatever you want to call it. Up until that point, they may have temporary access for their dialysis until their AV fistula or graft is ready to be used. So let's see, AV access, connecting the artery and the vein. We said some of the complications we see with this is thrombosis, which would cause occlusion, right? And infection. So again, important nursing interventions. Protect this and need this, right? So what are you going to do as a nurse if you have someone that has an AV fistula or AV graft? Limb alert bracelet, right? No blood pressure. Do we want to put any pressure on this? No. So don't put anything constricting. Don't put a tourniquet. Don't put a blood pressure cuff. Don't stick a needle in it. Don't start an IV. Protect it, right? Think of that as their kidney in a way. Protect it.
So if they have a fistula in the forearm, can you start an IV?
Use the other arm. Don't even go there. Use the other arm. And nursing assessment, you're checking for if it's patent. So nurses don't insert these, right? Like nurses don't insert central lines, but nurses assess for complications, assess for patency, and need to notify the provider if there's a problem.
I was thinking that we're gonna have a dressing as a DTC bag would, like they're dressing on it or not?
Usually they just wrap a little gauze or a little something over it, especially initially. Over time, they may not. They may just put the sleeve. Oh, the line, absolutely. It's a CVAD sterile dressing. Everything's sterile with this, right? Yes. With the catheter, the temporary catheter, it's dry, it's a sterile dressing. Absolutely. All sterile technique. So how, you guys tell me, because you know all about perfusion. I know that's one of the concepts you are very well educated in. So how is the nurse going to monitor for and assess for perfusion in the patient that has an AV fistula or AV graft? What? Check for a distal pulse.
Cap refill.
Check cap refill.
If they have any numbness or tingling?
Numbness or tingling.
Color.
Color. Temperature, CMS, color, temperature, motion, numbness, tingling. Listen for a bruise, set your stethoscope, you'll hear swish, swish, swish. And feel for the thrill, which to me it feels like a little electrical current going through. Yeah, like a.
Like vibrating.
Yeah, vibrating, that's what it's called.
vibrating.
So we know how to assess for circulation, right? We talked about this when we talked about access for angioplasty, angiograms, right? Always assessing distal to the access to make sure there's no nerve damage or circulatory damage. warm, pink, have refill, any edema, any problems, redness, drainage, edema, warmth, pain, any sign of infection, right? And then protect it. So here's a picture of the hemodialysis machine and the patient that's connected. Notice there's two lines. One is red, one is blue. There's clamps on it. Notice this cartridge or filter. That's taking the place of the nephrons in the kidney. That's where the filtration, so that's the quote-unquote artificial kidney. So the blood is circulated out of the patient through the dialyzer, right? We have to add heparin so there's no clotting. It gets through the filter, and then there's a solution called dialysate, because remember, it's through osmosis and diffusion that bad stuff comes out, right? All the toxins, protein, waste products, phosphorus, potassium, and then fluid. Because if the kidneys don't work, how is the patient going to remove fluid from their body? It's going to be done through their dialysis. Okay, so that's determined by their weight, how much, they always weigh them before dialysis and after, and the doctor will say, take off 2 kilograms, take off 3 kilograms. That's how they remove the fluid. So there's a blood inlet, a blood outlet. The blood goes through the filter with the dialysate, and that is taking the place of what the kidneys would normally do.
Are those things that happen already in there, or you put it out?
They add the heparin, the dialysis nurses. So we have the limb alert bracelet we put on, pre and post dialysis nursing assessment. So even if you're not a dialysis nurse, which at DaVita, many of our graduates have gotten jobs there. One of them was like the educator. We have, if you like this, you can apply to DaVita. They even will take new graduates. Because usually they contact me in the spring and they'll say, tell your new graduates if you're interested, they could apply to DaVita. So even if you're not the nurse performing dialysis, you're the nurse, your patients are going to dialysis, you're going to have them before and after. So if you're working in a hospital, you're going to have patients on hemodialysis, CAPD, so you do need to know how to take care of them. And it's a pre-assessment and a post-assessment. So vital signs are important, right? It tells us fluid balance, blood pressure, pulse, evaluating their blood work, BUN, creatinine, potassium, phosphorus, and their weight, pre and post. As soon as they come back from dialysis, it's very common for them to be hypotensive and symptomatically hypotensive. So you want to assess them as soon as they return from their dialysis treatment, their complete set of vital signs. If they're diabetic, their blood sugar, because depending on what time it is, they're down there for 4 hours. So if it's mealtime, I would think they'll feed them. Usually if they're going, like, if you know their dialysis time, we used to get early breakfast trays for our dialysis patients. Like they would send it up the night before and put it in the fridge so we could feed them breakfast before they went.
I know, now for some years, so other people dialysis center, they're not allowing their patients to eat at the center.
Probably not for infection reasons. So that's 4 hours of, not eating. So checking a blood sugar, monitoring labs, assessing the AV fistula, we said, for perfusion, patency, any sign of infection. Keep the fistula clean and dry. No pressure, no blood pressures, no vena punctures on that limb. The other thing is consider what medications they're receiving or you're administering prior to dialysis, because if they're dialyzed out, then it doesn't make sense to give it to them, because now they're going to just get the med dialyzed out. And frequently we hold their blood pressure and cardiac meds, because knowing that they usually get hypotensive during dialysis because they're taking fluid off. So some hospitals have a list of meds, Sometimes the doctors will write it, so you'll just have to check. Are you gonna be holding the certain medications? And usually if it's a beta blocker or an antihypertensive, we hold it. So post-dialysis assessment and complications, we talked about, it's common that they get hypotensive, they can develop a headache, nausea, vomiting. Muscle and leg cramps are common with people with end-stage renal disease in general. They can get leg cramps. But it is common during and after dialysis to get muscle leg cramps, hypotension, dizziness. They're at increased risk for bleeding, we said, because heparin is added to the dialyzer machine, infection, and hypotension. With the AV access, there's always risk of thrombosis, occlusion, aneurysm, ischemia, and infection. All of those would need to be reported.
What would you do for any leg cramps?
Sometimes they give quinine. Check their electrolytes, is it related to that? Massage, I mean, there's not a lot you can do. It's because of the shift of electrolytes, or their magnesium link you off, the calcium link you off. It's like that Charlie horse. Has anyone ever gotten leg cramps?
Oh, yeah.
Only a couple of them. Yeah, they are. Yeah. Yeah. So when, like, you know, you're really the fluid, you know, but it is not. All right, the second type of dialysis is peritoneal dialysis. How do you pick? It's many factors. It's not just up to the patient or the doctor. It's a collaborative discussion. What would be best for that patient? Do they have the ability to do peritoneal dialysis? We'll see that. They'd have to have good eyesight, good dexterity, or they have to have a family member that can do it. So there's, you know, different factors to take into consideration which form they pick, but there's benefits to the peritoneal dialysis because it can be done at home. They don't need to drive to a dialysis center. It's usually done 3 or 4 times a day. It can also be done automated on a cycler machine while they're sleeping, so that's a very nice way to do it. They go to bed, they hook themselves up to this cycler dialysis machine. During the night, it fills and wells and drains while they're sleeping. They wake up, they disconnect it, and then all day they can go about their normal activities and not be connected to a machine. Or the other continuous ambulatory method is 4 times a day, and it takes about 20 minutes to instill. Then it stays in the abdomen for about 4 hours and about 20 minutes to drain. So again, it limits, you know, if someone's on this schedule, if they want to go out to the store or an event, it's like, okay, I have about 3 or 4 hours before I got to get back home. So you can see there's pros and cons to both types. And again, it depends on the general health of the patient, their eyesight, their age. Do they have a family member? Are they able to get the supplies where they live and maintain sterile technique? One exchange, we call it an exchange, a peritoneal dialysis exchange, consists of the fill or instilling the dialysate. It's the dialysis solution. It's usually comes in bags of 2 liters, so 1 to 3 liters. Then it dwells in the peritoneal cavity using the lining of the abdomen or peritoneum as that filter through which osmosis and diffusion, when the blood and the capillaries come in contact with the dialysis solution, to filter out the, you know, the waste products and the potassium and fluids. So the dialysate dwells about 4 hours and then it's drained. And this all happens by gravity. So when it's instilled, the dialysis bag is elevated above their shoulder. Obviously, the higher it goes, the quicker it drips. And when you're draining it, you put it lower than the abdomen. So depending if they're sitting in a chair, you can put it on a stool. I know in the hospital, when the patients are in bed, they put it on the floor, but they put a pad. So there's a fill, a dwell, and a drain for one cycle. The dialysate solution, common sense, we want to warm it to body temperature, not put it in cold, because that would be painful and not comfortable. Never heat it up in a microwave. Why do you think they say that? Well, don't laugh. Back in the day, nurses, before we had those nice little warming devices, they'd stick them in the microwave. Why not heat it in the microwave? It doesn't heat. The same reason why, are you supposed to heat your baby bottles in the microwave? No. Because it heats unevenly. One part might be scalding hot and one part cool. So now, I know they have different devices. There's a little machine at the hospital. You put the bag in there, like, a half hour before your treatment to get it warm to body temperature. Very important. Maintain sterile technique. You have a catheter going into someone's abdomen, peritoneal cavity, right? So sterile technique is important because now you just had created a route of infection for microorganisms to get in. So whether they get in inside the catheter or from the exit site, maintaining a sterile field, wearing masks, wearing goggles, wearing gloves when you're connecting and disconnecting the transfer set. So the patient will have a catheter inserted, a peritoneal catheter, that will always be in them. And it will have a disposable cap that's usually saturated with some antimicrobial, like providone, iodine, or chloroseptic to keep a sterile cap on it. And when we need to connect it to the transfer set, the cap's removed and it's connected. And then there's clamps, because one tubing is going to allow the dialysate to flow in and one to flow out. So when you're flowing in, you want the outport clamped. So although this, the peritoneal dialysis procedure is in your Pearson skills book, as a new grad, you're not going to go out there and be like, okay, and you're going to have these patients. Right now, there's probably at least 5 people, 6 or more at Waterbury Hospital that need CAPD. You're not going to be like, if you're assigned a patient and you haven't been trained or taken the additional class, you're not going to do it. You're going to say, I didn't learn this yet, I wasn't validated. So the nurse who knows how to do it will do it. Then they will train you. They'll give you a class. It's an additional, 4-hour, 8-hour class, and validate that you know how to perform CAPD. Okay? So it's not hard. You just learn the steps. Sterile technique is important, and connecting it. And the key nursing interventions are monitoring the output. Because if you put 2 liters in, how much do you think you should get out? More than 2 liters, right? Because remember, maybe this patient might be voiding a small amount, but their kid, at this point, they're end stage. So for fluid balance, you should be withdrawing fluid. So if you put 2 liters in, you should be getting, over 2,200 out. Then that 2,200 or 2,400, whatever you drain, minus what you put in, that's quote unquote your urine output to be charted on the INO. Also important to observe the dialysate, the effluent. That's the peritoneal fluid that drains out after the dwell. So 2 liters is instilled, dwells in the abdomen for 4 hours through osmosis and diffusion between the blood vessels and the peritoneal membranes. It's doing the job of the kidneys, the filtering job of the kidneys. Normal is clear effluent, that's your drainage, which comes out. It should normally be clear and a pale yellow. It shouldn't have mucus shreds, it shouldn't be cloudy, and it shouldn't have blood or blood clots in it. So one of the key nursing interventions is assessing the fluid drained, which is called effluent. Hold the bag up to the light. Is it clear and pale yellow? That's normal. If it's cloudy, has mucus shreds, has blood in it, you're going to call the provider and let them know, because that could mean there's a peritonitis, which is a fairly common complication. this is just sort of a picture. Again, it runs in by gravity, not a machine. It's by gravity when it's CAPD. And then when the catheter is not in use, you know, it's pretty long. You don't want it just dangling there. Tape it securely, or they make special belts with pouches, like a little pouch or pocket to hold it in. So, you know, the patient has it under their shirt, you don't see it. It's not dangling to get snagged on something. Obviously, you don't want to pull tension on it, so just protecting it.
Are they greatly distended when they have this?
Some of them are, but some aren't. It depends. I mean, it's 2 liters. It's pretty, our abdomen or your abdominal cavity could hold a lot before you sometimes get. Like people who are internally bleeding sometimes can have like a liter of blood before they're like grossly, but they do tend to be distended, definitely. Abdominal distension, because now you put 2 liters or more into their abdomen. So any question about CAPD? So you are going to have patients on this, and if you're working on a unit, you're going to be trained. You're going to have an additional class. Just like when you graduate, you're going to have a class about starting IV catheters, starting IV access, how to do CAPD. They're going to give you these additional training classes. So nursing care, aseptic technique to prevent infection, site care of the tube, kind of similar to a PEG tube, but even more important to be sterile, okay? So sterile gloves, using Q-tips to clean around it, clean it very good, monitor for signs of infection, which are what? What are signs of infection? Redness, warmth, pain, exudate, or drainage, right? No bathing or swimming, because soaking in water with that wouldn't be good. They could take a shower. Weigh themselves daily, because that's how we monitor their fluid balance. Monitor that peritoneal drainage that comes out for any signs of peritonitis, infection, which is fairly common. And the symptoms would be fever, elevated white blood cell count, malaise, nausea, vomiting, abdominal discomfort, and cloudy peritoneal drainage, effluent. Check the exit site where the catheter is for signs of infection. Hernias can occur because of that increased pressure from that fluid, so they can get an umbilical hernia. Bleeding, pain, pulmonary complications from pushing up the fluid, pushing up against the diaphragm, and protein loss. So this patient on peritoneal, they're probably not going to restrict their protein, and they're probably going to want to make sure they're eating good quality proteins. If the drainage or effluent is cloudy, you're going to want to send a specimen to the lab for culture and sensitivity and start them on antibiotics. And one of the ways we treat peritonitis is put the antibiotic right in the dialysate solution that you're going to infuse. So nurses can add meds to that dialysate solution. They can add antibiotics, we've added heparin, I think insulin. So the doctor will order it, and obviously it's a sterile technique to add it. But if someone has peritonitis, they can give the antibiotics intraperitoneally. That's where the infection is. And depending on the extent of their infection, they may also have IV antibiotics. Because what is the concern with the infection? Sepsis. And if we can't use that form of dialysis for that patient, if they have peritonitis, now we can't just stop, right? Because they're not going to live if we don't have some renal replacement. Now they may need to temporarily get an access and get chemo. So the peritoneal catheter site, keep it clean and dry. Use the Q-tips just like when we use a wash under a tray or around any tube. Put some antimicrobial ointment. Yes? No, it's right here. You can see it, and it's in your skills book. There's only this one slide to say this, so I'll leave it there if you want to write. I bet you already all know this. Inspect for redness or lymphedema, I just said it. Put antibiotic ointment if there's any sign of infection. Use those pre-cut sterile gauzes. You know what I'm talking about? It's the same one we use for a trach or a G-tube. It just fits nicely around the tube. Keep it covered when not in use, just to protect it and protect it from organisms as well as any like trauma or pulling on it. Do not use creams with petroleum like Vaseline because they can damage the catheter. And then keep it secured, so, because it's pretty long, so it's not dangling to get stuck in their pants or pulled in their shirt. So they tape it, or they may have one of those Velcro belts with a little pocket. How's that? So the best option if someone's in end-stage renal disease, where they would have the best outcome, the longest lifespan, and the best quality of life, would be a kidney transplant. However, the need for kidney transplants is much greater than the supply, right? So out of all the people in end-stage kidney disease, a very small percent get to have a kidney transplant. But that is the best option. It is the cheaper option in the long run. It provides the best quality of life. It provides a better renal replacement. And they live longer. However, unfortunately, the supply does not match the demand, right? So there's two types of transplants, one from a living donor and one from a deceased, right? Is anyone here on the organ donor list? So, you know, we know that one way to get any organs that need to be transplanted is from a deceased donor. Another for kidneys is a live donor, because we have two kidneys, right? So someone who's healthy, has two healthy kidneys, can be a donor and give one of their healthy kidneys to someone in end-stage renal disease. Obviously, they have to be a tissue match, right? So any transplant, any organ transplant or bone marrow or stem cells, you have to have HLA matching, blood type matching. The average wait time for the people that are on the kidney transplant list is 4 years, 3 to 5 years. Again, there's thousands of people right now on the list that need a kidney transplant, and only a small percent will get that. Not everyone's a candidate that has end-stage renal disease. It depends on their age, their comorbidities. So if they have cancer or maybe end-stage heart disease or COPD, they may not be a candidate. If they have a substance abuse problem, they may not be a candidate. So not everyone is a candidate for it, but they do have an organization that controls sort of the equitable distribution of organs. So, because otherwise it wouldn't be fair, right? We don't want to give, you know, the kidney to the person who has the most money, or the person that lives in the biggest house, or the person who's a certain nationality. So it's called UNOS, it's United Network for Organ Sharing, and everything gets filtered through them to make it fair. Now we're going to talk more about kidney transplant in April. I think it's the last class. They put that content with immunity. So organ transplant is the topic, and I picked kidney because it is the most common organ transplant done in the country is kidney transplants. So for purposes today, just know that it is the best option for end-stage renal failure for all the reasons I said. However, there's not enough kidneys for everybody. Some people die while they're on the waiting list, or they develop some other complication and pass away. With any organ transplant, you need, you can have organ rejection, so they'll be on immunosuppressant or anti-rejection drugs pretty much for the rest of their life. Just to prevent organ rejection. And this is just a picture. Usually they do not remove the diseased kidneys. They add the new healthy kidney, they surgically implant it, and they anastomose the ureters into the bladder, but they don't remove the diseased kidney.
Why is that?
I don't know, they just don't. I think it would increase risk, yes.
Increased risk for bleeding.
Increased risk for
Connected
bleeding.
to
Do you know someone who had it, or you work at a transplant center?
yeah, I do know someone that had it, yeah.
Yep. Yeah, I found that interesting when I did my research on transplant, is they leave the diseased kidneys and they just add the new healthy ones. And again, it might not work right away, that new kidney, it might take a few days. The ureters are anastomosed, so you can even create a new ureter, so you're always monitoring for urine flow, signs of infection, organ rejection, hypertension.
How does that affect you?
He probably has great skin.
The adrenal glands, well, they'll monitor them, they may be functioning fine. Because they're on top of the kidneys, so if it's strictly a kidney disease, the adrenals may be fine. But depending on the disease, they may check the adrenals. But normally, no, normally that's a separate organ. So patient problems, again, thinking of what the kidney does, fluid and electrolyte balance, perfusion, acid-base balance, self-concept, coping, excess fluid volume, risk for infection. We talked about the treatment goals. We talked pretty much throughout this about the nursing interventions and the activity we're going to do next. We're going to talk more about interventions. But, it's kind of the same as AK. Monitor fluid intake, weigh the patient. Monitor labs, right? BUN, creatinine, potassium, phosphorus, GFR. Skin care, if they have a peritoneal catheter. Good protection and assessment if they have an AV, fistula, or graft. Prevent complications. Early detection and preventive measures are always better than treating end stage, right? Provide emotional support. Obviously, this is a big life-changing diagnosis. If we go on hemodialysis, depression is very common. A lot of teaching involved. The DaVita nurses are very good. The nurses will go out to the house to teach them how to do CPD. They'll make home care site visits all the time. And again, it's a real collaborative team that takes care of these patients. We talked about protecting the kidneys, avoid nephrotoxic drugs. So what are some nephrotoxic drugs? NSAIDs, certain antibiotics, contrast dye, good. Metformin. Follow the treatment plan, keep your follow-up appointments. Follow any diet restrictions, and the most common would be low phosphorus, low potassium, low sodium. Always, decrease drinking, smoking, and exercise. Drink plenty of water. This kind of says all the same stuff. So DaVita is a good source for you for further information, and the National Kidney Foundation. And what I've been doing is writing, because I know soon you'll be thinking about taking the NCLEX. So I've been looking at the NCLEX plan so that you can say, why is Professor telling us this? Why do we need to know this? Because this is the NCLEX plan. It says, manage care of a client on hemodialysis. Perform and manage care of peritoneal dialysis. Educate the client. Recognize changes in the client condition. Perform assessments. So again, we're trying to, meet all those RN, I don't know what you would say, that you need to know to be an RN, to pass the NCLEX.
Well, what are those links to? We don't have those.
No, you don't. That's an activity I'm going to do right now.
Oh, got it.
All right, so now this is the part I wanted to get to the class activity. So you guys also, I posted a study guide for you. So when you're doing the assigned reading, and the articles that I put are always optional, those aren't assigned, but Pearson is assigned reading, then this is a study guide, if you can get all this from your reading and the PowerPoint, it will be a good summary of the key points. And we're going to do a class activity, so let me make this, let me see if I can make it nice. All right. Again, we're trying to get you used to what type of questions might be on the NCLEX. So this is from the University of Maryland School of Nursing. They graciously make all their things available. You already did it?
Yeah, one of them, yeah.
Okay. So I'm gonna, again, it's just really, you guys, we want to get you ready and feeling comfortable with NGN style questioning. So here's some of it. So here's a little scenario. So you can read it. Can you see it or? No. I can't see it.
It's not
I
up,
don't know if I
right?
can make it.
Is there a link for us?
I can't make
That's what they did.
because it's a website.
So what is the three dots in the top right of the screen? And then you can see it.
Oh, thank you. It's nice to have young, smart people. All right, so take a minute and read the scenario, and then you could start sort of highlighting or underlining or in your mind saying, what's abnormal with this scenario? And vital signs. And then we're going to answer a couple questions.
Oh, God. Max temperature. I just found out. T-Max, temperature max. T-Max, bro. TJ. La 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 la.
That's exactly what I thought.
Look at I'm just going to make it a tad smaller so you can see. So one of the type of NGN questions a lot is saying, like, what do you think is going on? What do you suspect is going on? What do the signs and symptoms or cues alert you to? Or, what? And it will give you some choices. What? Wait. Tell me when I can scroll up one. I'm trying to fit it all in one page. Okay, so you got vital signs. What's concerning immediately with those vitals?
Temperature, blood pressure.
What else drops?
Oxygen.
So one of the new sort of things with the NCLEX and the testing is showing trends over time in vital signs, more like what you really do in clinical. Rather than now on a test question, you get one set of vitals, right? So it says 3 o'clock, the blood pressure was 150 over 92. At 4 o'clock, it's 100 over 64. That's a significant drop. So what condition most likely is experiencing? And it's saying pick one. What does everybody else think? What do you? Right. There's really ARDS, that's kind of, they come later, right? The patient stats are still okay. Cardiogenic shock, ARDS, those are, and multi-organ, those are all complications of sepsis, right? Yeah. So we're not there yet on that continuum. But what were your clues up here? The patient has a fever, he has red and inflamed fistula. Yep. So now the next one.
I'm watching you go.
Let's put that. So drag and drop is like the way they do it. Now the next one, which two actions should the nurse take to address the septicemia? So they give you 5, and usually they're going to give you 5 or 6. And what's good now, they tell you how many to pick. You know, instead of the question saying select all that apply, sometimes now they're telling you pick 2, pick 3. So think of the vitals and think of your ABCs, your priority, and think of how you prioritize your care. And you're only picking 2 items we're going to drag. So what do you think we should do?
Antibiotics. Oxygen.
So does everyone agree oxygen?
Yes.
ABCs, right? And then what?
Antibiotics.
Right, because the patient has an infection. We don't need, well, the head of the bed, you know, we could raise that if it isn't. We don't need to put epinephrine yet, right? And we don't need to intubate the patient yet. Let's start with some oxygen, right? So, and then drag 2 parameters the nurse should monitor to assess the client's progress to the box on the right. So again, the new next gen style NCLEX questions, sometimes they're called matrix. They're going to ask you to pick a condition in the middle, pick 2 nursing interventions, and pick 2 conditions to monitor. And I did this with something I did last year. But so that's what we're going to start here. The way they put. So what do you think is most important? The nurse should monitor all. That's what's most, if you had to pick 2 specific to the problem, what is it?
Blood pressure and pulse.
Blood pressure and pulse oximeter. Okay, so tell me your rationale for picking blood pressure.
Very low.
Good, monitor for septic shock. And we already know it went from 150 systolic to 100, so we better monitor that. And the pulse oximeter, because ABCs, airway, breathing, right? We're going to monitor for pain, and we're going to monitor urine output, maybe the liver enzymes. I don't think that's not. Okay, so then it gives you a summary of your answers. And now we're going to do the other one, which is a case study. Not on this one. But when you go into ATI, has some practice tests, it will, right? And certainly when you take tests and stuff, it will. Those were the right answers. Were you thinking they weren't the right answers? Yeah.
How was it? I like it so far on the stuff they like doing that. You like it? No, I like it.
All right, so here's the case study.
Yeah. I feel like it makes it
And this is a patient that's chronic glomerular nephritis. So that's an example of a cause of CKD other than diabetes, right? And she's only 35. Client is on automated peritoneal dialysis 6 months ago. Develops fever, vomiting, abdominal pain a day ago. Temperature of 102.4, heart rate 104, respiratory rate 16, BP 145/87. We have a weight, but can we do much with the weight if we don't know her prior weight, right? We don't know the baseline, so that we don't really, that's not that helpful because we don't know, is it up, is it down? Periumbilical tenderness, defense and then rebound pain. Erythema, creamy yellow exudate around the peritoneal dialysis catheter. Does that sound good? Yellow. And the dialysis effluent is cloudy. A culture was sent to the lab, and labs were drawn, and you have some labs. So the good thing, I know you've heard this, on NCLEX now they're always going to give you the normal reference range, so you don't have to try to memorize normals anymore. So that's major, because for the past 50 years, we had students memorizing more. So when you look at that, tell me some things that stand out to you as being concerning. But we already know she's an end-stage renal failure, right? So we expect the neon creatinine to be high.
Potassium is high.
Potassium's high, right? Kind of concerning because we know that leads to cardiac dysrhythmias. Sodium's normal. Calcium's a little low, not dangerously low. Hemoglobin on the low, low hemoglobin, but we know anemia with end-stage renal failure is a symptom. Now, the white blood cell count, what does that indicate to you? All right, and the neutrophils, elevated infection. So which 5 findings are the most concerning? So again, they're telling you how many to pick. So instead of saying select all that's high, it's kind of, I like this. It tells you pick 5. I'll go back up and you can see the vitals. So if you have to pick 5 of the most concerning assessment findings, what do you guys want to pick? Temperature. Okay.
Exercise.
We can only pick 5. So let me just look. I'm going to double check the heart rate, respiratory rate, and BP. Yeah, you know what? I'm not too concerned. Those are okay, right? She's a little tacky, but she has a fever, and the blood pressure isn't dangerously high, and the respiratory rate's good. So the temperature and the BO and creatinine are elevated, but she's an end-stage renal failure, and it doesn't say when she got dialyzed, but we do expect those to be elevated. So I agree with those 5. All right, so now it's the same scenario, the same labs. It's just hard to see it all. So look, I'll go back and forth. For each, and this is another format of one of the next gen questions you're going to see at NCLEX, and hopefully we'll start putting them on our test soon. It's going to give you a list of, usually it's 5 or 6. 1, 2, 3, 4, 5, 6, 7, 8. And it's going to ask you to pick, does it support peritonitis or end-stage renal disease, or it could be both, okay? So again, think of what you read, think of the PowerPoint, think of what you know about kidney disease. So a BUN of 46. Does that finding support peritonitis or ESRD? ESRD. Good. Creatinine. C-reactive protein. Potassium. Phosphorus. Hemoglobin.
ESRD.
White blood cell of 14,000. And neutrophils at 89%. You guys are back. See? In a way, with all these NCLEX changes, NGN, we're saying in the end, I think the students are going to do better and like it because it's giving you a real scenario and making you think rather than just this pop-up question that comes out of nowhere. So I think in general, this is going to end up being a good thing.
Whereas
Yeah.
like a question where you're like, well, I don't
So now, the labs I think are all the same. I don't think anything changed in the labs. No. Okay, the client is diagnosed with peritonitis. Drag the most appropriate word from the choices to fill in the blanks. Okay, the client has the highest risk for developing what? Sepsis. Does everyone agree?
Yes.
Because peritonitis could progress to sepsis, which would be a full body infection. Abdominal abscess, that's more of like a localized encapsulated infection. Cellulitis, well, it could be around the tube, and pyelonephritis. But we're most concerned with sepsis. Question number 4. The nurse reviews the lab. So now we have a microbiology report that came back of the dialysate effluent. What's the effluent?
The drainage.
It's what drained out. It's saying it has gram-negative rods. So even if you don't remember your microbiology, you know gram-negative rods aren't good, right? So based on the lab data, for each potential order, physician order, click to specify whether it's appropriate or not appropriate in the plan of care. So think of her in general. She's a dialysis patient, end-stage renal disease, has a fever, has an infection. Daily weights, is that appropriate for the provider to order that?
Yes.
Blood cultures. Peritoneal dialysis care, Q-shift.
Yes.
IV, D5.5 with 20 mil equivalents of potassium. Why?
Potassium's already a little on the high.
Calcium carbonate with meals. Yep, we said phosphate binders. Vancomycin IV. Maybe.
Depends on their kidney, or their end stage.
Well, what did we say? Usually, what's kind of what they start with peritonitis, if it's not sepsis yet. Intraperitoneal antibiotics. So they put the antibiotic into the solution they're going to instill. So definitely this one, Vanco, we have to be careful with Vanco. I'm going to answer your question in 1 minute. Why do we have to be careful with Vanco? Right. Do we give vancomycin to people with kidney disease? Yes, but at a lower dose, and we monitor their BU and creatinine. Yes.
My question was gonna be, does it matter if it's nephrotoxic, because their kidneys don't work?
Right, their kidneys don't work.
They're
They're already
already
end
down,
stage.
right, so.
Right. But they usually do intraperitoneally, but now if she's showing signs of sepsis or spread, they'll do an intravenous one. So we'll check appropriate. Now, Lovenox. Enoxaparin is Lovenox sub-Q daily. Is there any indication? It didn't specifically say anything about PT, PTT, or even that she's on bed rest. And she's 35, so I don't see an indication for it. How about Epogen?
How's their RBC?
We don't look at the RBCs, look at the hemoglobin. Don't look at the RBCs. So she might get it right. We said dialysis patients, she's 10, she's on the low side. Usually that's kind of the cutoff. So I think it's appropriate. Well, it's just, they may not. It's borderline. It's not dangerously low. If the hemoglobin's 7, 8, or 9, you're going to get it. They're going to be chronically anemic, so they're never going to be on the high side. All right, this is a good delegation question, which is you are gonna see these on NCLEX, where it's gonna say, can you delegate this to the nurse aide or UAP, unlicensed, or the LPN? And the LPN is kind of a gray area, because we don't necessarily teach you or assign you reading, and it may vary in different institutions. So there, we're just gonna have to make our best educated guess, and maybe some of our LPNs could help us out. All right, so for each nursing or each task, each intervention, let's say if it should be performed by the RN, the LPN, or the unlicensed assistant personnel. Vital signs.
UAP.
We could delegate that. The LPN and the RN could take it too, right?
Yes.
Dialysate exchange.
RN.
Sterile procedure, right? And advanced training. Daily weights.
UAP.
Peritoneal dialysis catheter care.
Okay.
I thought LPN too. LPN or RN? Intraperitoneal gentamicin.
LPNs can get that too, right?
But this would be added to the dialysis
Oh, yeah, okay,
intraperitoneal.
yeah, that's fair.
So if you're adding it to the dialysis solution, probably RN. Peritoneal dialysis catheter teaching. So anything with teaching and assessment the RN owns, right? And this is no disrespect to LPNs, because at DaVita, they have a lot of LPNs working in dialysis, or traditionally, LPNs were very strong, important healthcare providers in dialysis. Now, question 6 of 6. The nurse teaches the client about peritoneal dialysis catheter care. Click to specify whether each statement indicates the client understands the teaching or does not understand. And again, I know if you didn't read the skills book, but I did, it is in the assigned. This, you might not know everything, but think of your common sense. At this point, you do have a lot of background knowledge about it. So if a patient said, before cleaning, I will wash my hands with soap and water and put on clean gloves. And I don't have the answers to this, and then I looked in 3 different resources. At home, it might be clean, but in the hospital, we probably would be clean, but some of the procedures, I think in the skills book it says sterile gloves. I should remove trust or scabs at the exit site. What? But then a couple, when I read it, it did say take a Q-tip and remove the crust. So like, obviously, we're not gonna put this question on our exam, because it's too contradictory. If you have sources that contradict each other. Hold the catheter in place to prevent injury, that's easy. Scrub the site vigorously with antiseptic solution. I would say gently, and do a circular round. I will put antibiotic cream around the catheter with a cotton tip. Yeah. So the acid trace and ointment. I will not use creams with petroleum because they can damage the catheter. I will leave the exit site open to air or covered by loose clothing.
No, I thought you put a bandage in it, right?
Full of gauze, or if, it depends, if they had it in a long time, they may have one of those belts with the pockets. You remember when people are at home?
Normally you leave it open to air.
No, in the hospital, we cover it with gauze, if they can secure it. Nobody that doesn't understand. We want to keep it covered in the hospital.
Guys, you guys know you could get a half a dozen specials at Dunkin' for $3 and hold on for there. You guys can get it.
All right, so I'm going to encourage you guys, if we can do some of this right now. Does anyone want to look at the key points? Did any of you guys? If somebody wants to do it and they feel like you did a good job and you want to post it to share with classmates on discussion, you can. Or we still have a few minutes and we can see what people have here. So what do the kidneys help regulate or keep in balance? Acid-base balance, electrolyte balance, red blood cells, excretion of waste products, vitamin D, which, there you go. So we can say food and electrolyte balance will kind of cover, well, that's vitamin D. And then phosphorus and calcium, right? You guys can write in the normal B1 and creatinine. Explain GFR. What is the normal range? Does anyone want to explain what GFR is? Good. It says, she said, amount of blood being filtered by the glomeruli per minute. And what's normal? Like 100, 120, right? What are some risk factors for chronic kidney disease? Diabetes, hypertension, untreated AKI? Excellent, good. Actually, in something, again, you guys can read my first 10 slides yourself. Also, there's a increased incident with certain races and nationalities, so be aware of that, right? Nephrotoxic drugs, avoid nephrotoxic drugs, smoking, family history, lupus. Define ESRD stands for what? Okay. End stage renal disease, which was stage what? 5, and what was the GFR? Good. And at that point, what treatment options do they have to have? Renal replacement, dialysis, kidney transplant. What are some of the most common? There's a lot of symptoms with uremia, right? Because it's multi-system. What are some of the most common clinical manifestations? Yep. Okay, good. Anybody want to add any other clinical manifestations?
Uremic encephalopathy?
Encephalopathy, so those are sort of kind of what she was, the neurological change of LOC. How about the itching, pruritus, right? They have sort of a sallow colored skin and blood pressure, usually blood pressure is high. They can have fluid retention, right? Edema, fluid retention. List some of the common drugs used for pharmacological treatment and their purpose. So the first example I said, ACE inhibitors are used to control the blood pressure. What are some of the other drugs we said we commonly use with the later stage chronic kidney disease? Epogen for red blood cells to treat anemia. What else? Phosphate binders, not phosphorus, phosphate binders. What other drugs did we say? Maybe on a calcium supplement. They're usually on a couple of vitamins. What else? Folic acid, iron supplements for the anemia, vitamin D. They're pretty much always on calcitrol, vitamin D. Because one of the clinical manifestations is bone, soft bones, osteomalacia, osteoporosis, leading to increased fractures. Lipid-lowering agents. And then if their potassium's high, the best treatment is to get stat dialysis, but they may give them K-oxalate if for some reason they can't dialyze them right away. What are the key general dietary adjustments? Because remember I said, the specific diet is going to depend on what stage of CKD and what treatment, right? So prior to dialysis, they may be restricting protein, once they're on hemo, they probably don't need to restrict. But in general, what were some of the dietary changes or limits we needed to do? Low phosphorus, no salt substitute,
Good quality protein, no red meat.
avoid red meats because those have phosphorus. Good. And colas and bottled teas, they have phosphorus. So low phosphorus, low what else? Low potassium, low sodium. Protein depends on the stage of what treatment. And sometimes you're on fluid restriction. We have many dialysis patients who need to be on fluid restriction. I think some of you have had patients that are dialysis that, because if they're getting dialyzed 3 days a week, and they could gain 4 pounds in one day of fluid, and that's not good for their heart. So they may also be on fluid restriction. All right, so our main goals that we have here, to maintain fluid balance, what are 2 interventions?
Fluid restriction.
Fluid restriction, strict INO, daily weight, good. And in general, you know this from heart failure, weigh them at the same time on the same scale with the same clothes on, right? Maintain electrolyte balance. What are some nursing interventions for that goal? Supplements, diet. Monitor labs, right? That's a nursing intervention. Monitor their labs. They're going to have frequent labs. To prevent or slow the progression of chronic kidney disease, what are some interventions nurses can do? Good. Control their diabetes and control their hypertension. Excellent. Teach the patient. Teach them. Teach them to avoid, because you know it, but not everyone knows, the layperson doesn't know. You have to teach them. So, like I know someone is stage 3. I said, well, make sure you don't take ibuprofen, no dyes, and whatever else I said. And they're like, oh, I didn't know that. You know what I mean? So the teaching to prevent, to try to keep their kidneys as healthy as you can. Teaching is real important. Monitoring for progression of the disease, following up, get those consults in as, whenever they're appropriate. Monitor disease and treatment complications. Well, and this is where a lot of your NCLEX testing or even our exam questions, we're always asking you for signs and symptoms, right? What are signs and symptoms of the disease? What are signs and symptoms of the complication? Because you have to know that to recognize it, to recognize those cues, right? If you don't know the signs and symptoms of sepsis, how are you going to recognize it? Patient demonstrates knowledge and ability to comply with treatment and participates in care. So there's a lot of, you want to encourage the patient to be as involved in their care as possible, as physically possible. So teach them the medication, have them, explain to you about the meds, teach them, if you have to teach them their CAPD or how to care for a catheter, return demonstration. We're always teaching the patients. And then last but not least, we could compare and contrast hemodialysis versus peritoneal. So what are some differences? What? Hemo's hemo and hemo blood, good. So what's the difference between hemo and peritoneal? The access site, good. Were you meaning root access? So access, right? Peritoneal, they have a peritoneal catheter in their abdomen, surgically implanted, that stays there. And for hemo, they either have a temporary hemodialysis catheter, or they're going to have an AV fistula or AV graft, so different access. How about the location of the treatment? CAPD can be done at home. It can be done 4 times a day for a nighttime hookup to a cycler machine. Hemodialysis, kind of new, and not a lot of people get home hemo, but it is a option. Or they go to freestanding hemodialysis centers, and they can also perform hemo and CAPD in the hospital, right? And they do. What? Peritoneal, there's a dwell time of about 4 hours. How long does the hemodialysis treatment last? About 4 hours. But hemodialysis schedule is usually 3 times a week, right? Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. CAPD is 4 times a day. How about complications? What are the complications, main ones of hemo? They can get hepatitis. What? Blood loss, bleeding.
Hepatitis.
What's a really common one? Hypotension, good. And their fistula could clot or become thrombosed or a problem, and that's their lifeline. What are the complications most common of peritoneal dialysis? Peritonitis. And nursing interventions for both, what's common? Monitor all their labs, their blood work, their electrolytes, their fluid balance. Monitor their vital signs.
Monitor the site.
Monitor the site, good. So monitor their access site for hemo, or their peritoneal catheter, site care. Aseptic technique for everything. What? All right, any questions? All right, so we're going to try to do those. Did you find the NGN activity helpful?
Yeah.
We're going to try to do those so that your